MPDSR investment case, please give your inputs. The objective is to identify top priorities that we can run with. We can say that for these next several months, we will champion ABCD. That's the objective why we are here. To sensitize you once more about it and also to tease out the top priorities that we want to run with. We want Kenya to be a place where people will come to benchmark. How did Kenya reverse their numbers? It's possible. I believe it's possible. So we can do it. We want other jurisdictions to come and say we also have similarly high numbers. What was the magic bullet that Kenyans did, that Kenyans had? That's what we want. And you are the people here, the brains here, that will help us to deliver that. Are we in agreement? Do you believe that it is possible? Is it possible? Yeah, it's not possible if you don't believe it, but if in your head you conceive it that it is possible, then it will be possible. So I want to thank you so much, and at this point, I want to invite a few speakers to give us a few remarks, and then we will progress with the program. So Dr. James Amenge, he is the co-chair of the Intercounty MPDSR initiative. So Dr. James Amenge, come and address the meeting. Makofi kwa Dr. Amenge.
Thank you very much, Mabel, for the great introductory session. We highly appreciate the work that you do behind the scenes. Ladies and gentlemen, our colleagues, good morning. Noisemakers, good morning. Noisemakers, do not speak that slowly. Good morning. Say hi to the neighbor next to you. Mwambie karibu sana. If you're next to someone coming from Nairobi, Kiambu, Machakos, Kajiado, mwambie please learn to keep time. I'm hitting below the belt. Huh? Thank you very much. It's an honor to be here, a great honor indeed. Joined at the hip with one goal, the goal of accelerating elimination of preventable maternal and newborn deaths. I dare add elimination of preventable severe mortality, because sometimes we end up saving life, but still families continue to suffer the consequence of pregnancy-related complication. There are deaths that happen day 43 following delivery or termination pregnancy, and yes, we do not count them, but they came from a pregnancy-related complication. A baby being born with asphyxia and a family surviving with a baby with cerebral palsy, who has to be fed, supported, everything done for them. The family, to them, it's a huge deal. That a baby is born preterm, and because we did not do the right thing, they end up suffering from hearing loss as a result of prematurity. Or even neurological damage as a result of that prematurity, or failure to institute and that CPAP on time. And the family has to live with a child who is dumb and deaf. The baby did not die. But for what the family was looking forward to, which is a healthy baby who is able to succeed them. And I know Africans, we are running away from children taking care of their parents, but still, at the back of our minds, there's always that desire that your child will become independent. And when there's something for the family to be done, we have more hands. It is no longer just your pair of hands alone. When a family doesn't achieve that goal, it becomes then a pain that they live with. So our journey goes beyond just preventing the death. Our journey goes beyond what everybody's talking about, but we see the big picture. And so my heart feels excited by the fact that you can come from as far as Kilifi to as far as West Pokot, as close to as Machakos where we are. And we can all converse and just share ideas. And you realize in this room, even with the limited number that we have, the variety, the variability of ideas that comes forth, the fact that we can all come together with a single purpose, breaking the borders of cadres, the borders of counties, the borders of seniority, the borders of gender, breaking the chains that usually put us in silos is a huge thing that I would want all of us to consider and celebrate. So welcome home. Welcome to the Intercounty MPDSR initiative. This is where we all belong, and even more who are left at home, who are left our places of work belong here, because we aim to bridge the gap between the bedside and the leadership. And in that process of bridging that gap, we're basically saying we are ready for everything, whether it is name calling, whether it is breaking people's doors, whether it is making the chief feels that amekuwa tumemlenga tukaenda kwa director directly. For us, we are with one purpose. Allow me to take this opportunity to welcome us all to this session, today and tomorrow. Please, as Mabel said, don't feel restricted. If at your place of work usually you have to go through certain bureaucracies, or lazima uende kwa head of unit where it work, head of unit, then there's head of department, then there's director of division, then there's senior director, then ndifike kwa CEO. What this space has allowed us to appreciate, that sometimes those bureaucracies are created to manage us. And it takes a soul that only fears Ujimoto, to break those chains and have things to move. And these are from lived experiences. Director Kata will tell you a story about Tana River and Kilifi. And I'm so happy to have my senior, Dr. Noreen. You have no idea how much we've loved that you are present. Kilifi is going to places. So feel welcome, ladies and gentlemen. It may be your first time today. It may be your last day today. We pray it is not last. Sawa sawa. So si tujiambieni basi karibu sana. Mabel, back to you. Thank you so much. It's been my pleasure. Thank you.
Let's give him 3 hearty claps. 1, 2, 3. I think that was 3. Thank you so much, Dr. Menge. He really does a good job as one of the co-founders of this initiative. You will get to hear more from him as we continue with our program. So we also have Katra. Katra is a Director of Health Services at the COG. She will come and introduce herself fully, because I've only said one name, and share with you her interests, her passions, and also give official opening remarks, and then start us off with the first presentation. So she's going to be standing here for a while. Mpe makofi akija to motivate her. Oh yeah, sorry. They'll introduce themselves. Watch how they introduce and then
like there are more people. I think is it opposition and the people who are seated behind, we have to occupy here. We have to fill this so that we also have media in the room. So this side looks empty. This other side has more people.
So you introduce yourself. Say your name, where you're coming from.
Good morning, everybody. Good morning. My name is Mary Wayego. I come from Kenyatta National Hospital. I'm a neonatologist.
Thank you. Good morning. I'm Dr. Munya from Kitui County, an OBS-GYN.
Okay, Director, now the rest will introduce as we go on. Please give your official remarks and then give us your presentation. Thank you.
Thank you, but I have to transition you from where you are sitting. You can't sit alone. And the lady who has just walked in, Karibu Sana, but I want you on this side. And Charles, I also want you on this side so that we balance. Kindly note, we also have media in the house. So you brighten up, you smile. I know it's a meeting, but you also want to enjoy ourselves. Good morning once again. I know we are not good on time, but the good thing is like we are going to serve tea inside. So we'll be having a working tea so that we continue with the conversation. I want to welcome you all to this meeting. My name is Katra. I know we haven't met with many of you, but for those who have met, for those who have not also met, you must have heard about me. We are all here for a reason. You are here because you have been touched, and you are here because you want to make some decisions for this country. Amenge has rebranded us to be noisemakers, and I think in this country you can only achieve when you are a maker. Just the way when you are a graduate and you are a university student, your demands are not met, you throw stones and you are listened to. As you are throwing our stones in another way. So I want to welcome you to this meeting. I have a speech, but I like reading out of the cuff. When you read speech for COG, you read on behalf of 47 county governments, so it's a must to read. But we don't have a podium here. I just realized there is no podium. So I'll strain a bit, so I'd rather also mix. So, karibuni sana mwanzo wale wametoka mbali to Nairobi County. But I realized the people who came from furthest are the people who are here first. The Nairobians have came in late. The guy from Marsabit was here even ahead of me. Kwale was ahead of me here. You've heard Kapenguria is here. Do you know how many kilometers Kapenguria is? But she was here ahead of somebody who came from KNH. And somebody who has come from Machakos. So that is how we are, but nevertheless, I know we are quorum, we're expecting 30 packs, but nevertheless, this is a good quorum for us, and we all know why we are here. We are all here because God has touched us in one way or another. We are all here because we want to remove barriers to access each other. We are all here to remove barriers between the leadership and frontline healthcare workers. We are here because we are the healthcare workers and we know our demands and we know what is not working well for the counties. And we are here because we want to put our heads together to do a lot in terms of changing maternal and newborn health in this country. A lot has happened in this country. Many investment has happened through development partners. Many investment has happened through the county government. Many investment has happened through the national government, but our figures remain unacceptably high. We are still losing newborns. Even as now we know, if you just ask somebody who is a program officer at the Council of Governors, they'll tell you like we are losing 15 mothers in a day. And they'll tell you we are losing 52 newborns in a day in this country. That is how we became passionate. Even as we work with data. As we engage the leadership, we tell them the truth. This is what is happening. But what is it that you're not doing right? Where do we need to go? How do we need to re-strategize? How do we need to refocus? The first time when the Intercounty champions came to us, I think a group of almost Initially, I was told 47. I'm like, where our boardroom is small. So come with a few. But later on, when I saw the discussion, I felt that I needed everybody on the table. But we started so well. I think this was last year. Just calculate around 9 months ago. We were already passionate, but we found those who have injected to us also the passionometer. And so we found a group that are ready to work with us voluntarily. And we felt that together, I think we can be able to do something bigger. And the last 8 months, I think, has been a progress for us. As Council of Governors, we don't talk, but we walk the talk. And there are things that we promise to do, and it is really working for us. But it cannot work for us only as the Council of Governors. It can only work for us when we engage the people who matters most in the discussion. And when we have a table like this, a room like this, we can be able to face each other and talk the truth. The last, I think, 9 months, we were able to come up with an investment case. I know most of you have participated, and it came from you. It is you guys who told us what needs to go into the investment case. We came up with a logo that we'll brand ourselves with, the Intercounty MPDSR. We all participated. I remember the faces that were there. We came up with a website. We all agreed it can work for us. It is very beautiful. You will see it. We also came up with a dashboard. Right now, as we speak, we have a live dashboard. The governors have a link. They can access and they know what is really happening in their county. We just want to tell the governors to be responsible. This is their figures, how mothers are dying in their county. But the dashboard was giving us data from KHIS. It's interconnected. But what we are trying to work on, and what we've just tried to work on, is to have real-time data, not only on the audits, not only on the data that we've lost, the number of patients or clients that we've lost, but if you do also a near miss, you do a very good case, you do many good things around intervention, we also want to have that real-time data in the dashboard. Our dashboard is really working, vibrant. We are also trying to link it up with GIS, so that if you come from Kwale County, your governor can see the GIS map of all health facilities in your county and what is really happening. So we just had a meeting with CHRIO last week, or it was this week. This week on Monday, we convene all the 47 CHRIOs. We have a consultant who is doing for us a GIS for all the sectors that have been devolved. So health has a lot of data. So when you walk into that GIS, you tap on Kwale County, you find all the geographical distribution of the facilities in your county. You'll also find where mothers are dying most. If something is happening in that facility, they will upload there. So the CHROs can be able to remove that data and put it in the dashboard so that it is interconnected and it is live. But we said we will not do it only for the counties. Right now we have neonatologists from Bagavi, from KNH. That's a national referral hospital. We have Dr. Amenge, also obstetrician from Bagavi. If you want us also to do for you that, from where you sit, you can be able to see that data. For example, what are you doing as an obstetrician? What data is visible for KNH? How many patients were referred to you from from other counties that you are already trying to track? So from comfort of your seat, the neonatologist will be able to know, I've received 50 patients, neonatologists, from Mama Lucy, from Kiambu, from Ranga, from what? So we want to interconnect. So we will not put the visibility only for the county, but the referral facilities also will have that link so they can be able to track on the number of referrals that they're getting. We want to maximize it because mothers and patients do not have a boundary. When you want to access services, you walk anywhere. The facility that is nearby is the facility that you'll access. For example, I come from Garissa, and I got labor pains in Nairobi. I'll not travel back to Garissa to go deliver there. So you have to access the facility that is nearby you. And that is why we are even migrating to digital health, so that at least patients' data are there. So any facility you walk in, you can be reimbursed. So that is why now we are saying there is no boundary between national government, there is no boundary between county government. Patients do not have boundaries, so they must access services, and we must give them the services that are of quality and are of basically high quality and accessible and also affordable. So the reason as to why we are here today, We've made milestone. Partners are showing also a lot of interest with the Intercounty MPDSR team. They are feeling that these are champions. These are the people who can change the figures in this country. We had an IMNCH conference, and we were in panel, leaders were there, partners were there. I think people have started seeing value of having the frontline healthcare workers in some of these panels because they're telling the true story. As council, we've removed the bridge between a frontline healthcare and the governors, who are the policy makers. And I remember saying, please, even if you're not given opportunity, just go see the secretary and tell her, I want to see the governor. Then CHMT should not be a barrier. This is a leader you've elected. You have something. We just need to be very aggressive. At the end of the day, when you walk into that office, you are not begging for favors. You are walking inside there to show the governor that this is how we are doing badly. And I lost this mother last night because simple drug like abetocin, which costs 85 shillings, is not here. I lost this baby because Kafensi Treatment was supposed to help this child, was not there. It's a honest conversation. And that is where we want to reach. We've already started reaching there, and I know we will reach. So, from the investment case, many partners now want to engage with our investment case. Next week, we are going to have high-level meeting with Gates Foundation. They have done a courtesy call to us, and together with a few intercounty, just your caucus, to meet with them and come up with the priority areas that we can be able to tackle within the next 1 year. So we already have an investment case, so we don't want to reinvent the wheel. What we just want to do in this meeting, which is today and tomorrow, we have a consultant who has developed for us the case. He can be able to project it. He can be able, because I remember telling Charles, give me what is the priority, maybe within the 6 months, the first 6 months, and then the other 6 months, so that even as we engage Gates Foundation, we'll tell them this is the priority. Gates Foundation funds many people, including COG. So even what we want to do, apart from the resources that are available at the council, we want to tell them to convene for us all the partners in Gates who are like in the Ramka space. We tell them we need this, we need this, we need this. As much as the investment case will limit us, we can go unlimited. You can even tell us from your experience, I think in this investment case, there's something that we've missed. Can we add this? So it will be a priority for us. But all along what we want, I always say resources are not a problem. It is how you need to do the resources for the right purpose. And it is how you need to involve the technical people to give you what matters most. Remember I said we are all here because we were touched in one way or another, right? And we are targeting the people who are like, can be able to come and talk to us and tell us the truth. We will stop complaining. We have to stop complaining. You know the way you walk into a hospital in the morning, some of us have been, I've been a healthcare worker, but now I'm not practicing. But the frustrations, the frustrations. Sometimes you want to do something, but basic things are not there. The complaints. So we have to stop complaining. And I'm saying, like, if you are a whole manager in, for example, a department, you walk into Medsup office, we tell him, we are not working. We can't work. It has to be very honest. If they transfer you, let them transfer you, but it has worked for the people you have left. Because you will not be dismissed. It's a honest conversation. And I think even in such a situation, when people see that like you are delivering and you want this and you must deliver, they even fear to lose you. But we must have honest conversation. We must bang tables. We will help you to unlock where you are stuck. You just whisper to us and tell us, come to my county. We've been in Tana River. We've been in Tana River. You know, I'll give you that update. And I think of the inter-county champions, we say we will be walking into counties. We've started with 2, so we've achieved. And I know next month we'll also go to another 2. So we have. And the people we are going with are you guys. We are going with you. We're not going alone. We went with 3. So next we'll go with another 3. Another time. So then you don't need to go to your county. We'll go to another county. What we saw and what we fixed was, it was very impactful. Let me just say it was very impactful. And some of us found ourselves to be like when we were young and when we were in those spaces. Kinamenge were just looking at me. I think I was mad, but it worked. The madness worked for me because the governors could listen to me. And the good thing is the healthcare workers already gave us the information. So Every time you say, Excellency, you know this, he banks. Because the CHMTs were there and they cannot be able to deny. Your Excellency, you know this, then he say, what? You know, what? Like that. We are just finalizing that report and give him high-level resolutions of the immediate, what needs to be done. But we've injected some of them. We even have a clip. In Kilifi, the governor, when we walked out, he went to a burial and he was talking to the on PPH. He was actually instructing the CHMT of Kabetosin up to the least, the lowest level, dispensary. And that must happen. So when we are giving him report, I know he will sit and he will look at it. There was a very nice clip. We can be able even to share with you. But that is how leadership now will commit. But they will also commit when they see COG, they know now this is something real. But you know we are not working alone. So it is you to give us information that you need us to package. We are coming to Kwale. And we are coming to Taita Taveta. So that is what is happening. One of the other action points that we said we must work is about webinars. I know that also came from the champions. I think so far we have had 6 webinars, national webinars. And we're having one that will happen 30th. The CS will be there. We'll have 2 governors. Heavy conversation on teenage pregnancies there because there's a percentage that also contribute to maternal death. So please join, make it viral. We are all champions. Katra will not be here tomorrow. I'm mentoring some of you who are also upcoming. You can take my position. So we need to talk like me, talk like yourself and add what you've learned from other person and add your temperature, right? I'm glad that Madam Emily is here. We always say, when you retire with a library. You retire with a lot of knowledge. But it is age. It doesn't matter. That's an age factor. And when you retire, you are not tired, right? So there are people who have rich experience. Even as we are retiring soon, I have some few years. So when I retire, at least I know when I look back, I have people that I know I will look up to and like, where have you reached because I gave you this? So we have to keep on passing the baton. Please, everywhere you are, make sure you talk passionately about maternal and newborn health. Let us change the figures. The national government knows this is a disaster. I was with CS, was it last week? We were in Naivasha with all the chief officers of health. We were taking them through their data, real-time data. And we hijacked the CS because he was there for KMA and the PS. They were not coming for our meeting, but we told them you must come and listen to us. Actually, they gave us more airtime than those who have invited them. And he talked very passionately. The CS talked so passionately. I told him, I only have one request for you, Mr. CS. What you just need to do is give us the basic commodities for free. Even if KEMSA owes us huge debts, they should not tie the pending bill with the basic commodities. So these basic commodities should be finding themselves in the hospital. And he promised to do a letter. I think we've already done to him the resolutions. He will do that later. So we don't want you guys to get frustrated. Sometimes you want to work, but the resources and the environment doesn't look good. But don't complain. Work into that when you have your stethoscope or when you are from theater, gown, blood, and everything. Walk into that office and tell them, I've lost a patient because of 1, 2, 3. Sometimes use also other, like nurses and noisemakers in the department, as we used to unlock things for the doctors. So use the nurses you are working with. You work, all of you say, you don't even need an appointment. You lost a mother. There's no Kabetosin. Walk into the METRIP office, call the 3 branches, the nursing office, the administrator, and tell them, we'll not continue killing more mothers. You have to avail this or we'll stop all operations. Simple. Simple. And then you sneak something into the CHMT walls and, you know, people will wake up. There's a county that you went, a whole year, CHMTs never met. I think I was mad. I've never done that even when I was practicing, I was in management. But all those are things that we need to change. Things have to change for us. We can only achieve when things change for us. So we need to walk out of our comfort zone. I know you guys are very busy. We were having a lot of headache even in convening this meeting because people are not confirming, people are busy. We know you are busy, we are also very busy. Actually, we prioritize Intercounty MPDSR in the directorate because we saw that we have passionate people. But that doesn't mean that we don't have other responsibilities. Sometimes it's also very fatigue, but we need to see how we can be able to flexible and find time for this particular, because like it also came from you, we also had the heart to drive this. So we must find time for ourselves to engage and to make sure that we unlock something. Otherwise, without you, we can also not achieve. Tuko pamoja? So today's meeting is basically to go through that investment case, get priorities. We also change experience we saw since the last time we met. What did not go well? Even in your county, did anything change? Because you came to a meeting, did anything change? If you have issue in your county, tell us to come. By the way, we can even walk to National Hospital. The CEO KNH is a good friend of mine. CEO KUTRH is a good friend of mine. You know, we connect somewhere else, eh? So we can even have a discussion. Now we don't have a barrier. We can say national government and county government, because the figure of Kwale County will bring down the figure of National Referral Hospital. We are just using one data that is coming to the KHIS to give us the figures of the national. Otherwise, kama kila county ingekuwa tu ni yake, kuna wenye wako 112, kuna wenye wako at 400, kuna wenye, my county is doing the worst. Worst. Actually, I'm planning to go there. It's the worst. And I don't know, but we'll just give it our best, because in one way or another, God will hold us accountable. All of us have been leaders in this country. What simple thing did you change? What simple thing did you use to save a life? God gave you knowledge for a purpose. Sindio? God gave you knowledge for a purpose. So we must down the tool of making noise. We need to wake up, open up, brainstorm. Where you have bottlenecks, engage us. You have all our numbers, take it. Hata ukinikosa unaweza chukua namba driver, tanitafuta. We work. Just whisper to me, come to my county. Just text me. The good thing about this engagement of the champions now, I'm getting messages even at midnight. But I see it in the morning. I feel so bad. County X has referred this patient to us. They delayed with this patient. Now tomorrow I already have a mortality. Please join our audit. Because as a county now, we are trying to stop death. Eh? But there is a county that is not responsible. We have obstetrician, for example, in one county. Then, like, they are not available. So you send a patient on an ambulance bleeding, some again 30 or 1 hour to the neighboring county, which has an obstetrician. And you end up losing the mother. For those who are in DEFCON, I think you had one of the bad cases, and the governors really felt emotion. Referring. By the time now the ambulance has reached, they want to pick the patient, the vehicle doesn't have fuel. That's stupid. And you know, it's good that the leaders actually listen to those things. So, you know, if it doesn't come out from you, it doesn't. And we want now MPDSR to be actionable. We don't want a passive audit. We want an audit that is actionable. Include us in your audit, send us link, we will join. Where we can make noise, we can make noise. For me, I'll just call a governor, he will pick. But for you, you can't, and you are in that county. I'll even use the chair of health committee to be that governor and brief him on what has happened. Right now, we have governors who are champion. Last month, we had a side event in New York, very high level, in the Commission of Status of Women on what we are doing as a country with our intercounty. And I think we went with some of the champions who had visas. US to get visa is a problem. And it worked for us. Many people actually see what we do. And governors actually go to those side events. So please, let us work together. Let us see, don't only focus even on your county, focus also on your neighboring county, because they're the ones who give you bad cases. So you must harmonize referral system. We must have robust referral system in all the county. If you don't have ACLS in PGH, you don't have a BLS in one of the facilities, the lower levels, your referral system is dead. You can't put a patient who is bleeding on a pro box. That is unethical, as much as at that particular time you want to save. But remember, it is the driver and the mother bleeding with a relative behind. So you've caused more death than even, you've caused more pain than even, you rather struggle with that patient as you wait for an ambulance. That's what I wanted to say, but I want to take this opportunity to welcome you all. We can share these remarks on WhatsApp. Let it be very consultative. Open up, let us have honest conversation, and just the way I said, we need to work together. We need to work together. Let us not complain. Let us give it our best. Let us give ourselves solutions and not problems. In our COG, if you walk to the CEO's office and you have many problems, she'll tell you, don't tell me your problem, give me resolutions. So we are used to that. So I also don't want you to give me problems. Give me resolutions of what we need to do. Sindio? So karibuni sana. It is a 2 days, 1.5 days, probably, but very consultative. So let us vibe up, get to know your colleague, shake hands. As much as you are here, I hope there are people who are working. So we have enclosed facilities. The facilities are also working, because I don't want to bring you here and then I'm told, oh, you know, in Kajiado, a baby died, the neonatologist was in Mlolongo for a meeting. God will not forgive me. Sasa, to shut down laptops kidogo nini tukue tu na bit. Then I told you we have media in the house. I want to document all our stories. So be vibrant. We will do a lot of energizer. When you are down, tell us, hey, we need to chill. We mix things, sindio? Karibuni sana. So, Mebo. Oh.
Makofi kwa Katra. Let us give her factorial 3 in a very organized way. Okay? So we start with 3, 2, and then 1. So let us warm our hands. We're going to give a factorial 3. Warm your hands. Okay, let's go. Thank you so much for your remarks and for setting the stage in terms of what we need to achieve in our 2 days workshop. I think all of us are now clear with on what we want to achieve. So at this point, before we go to the next program, I'll want us to play a short documentary. So please be attentive, watch the documentary. And then after the documentary, we can have our tea. We can have 5 minutes to go pick tea and sit with it so that we save on time, okay? So, Eliud, you can play the documentary.
Are recorded every year, translating to 16 mothers and 92 newborns lost every single day. These are not just numbers, they represent devastated families, future generations, and lives tragically cut short, lives that in some cases could have been saved.
The arrival of a baby in African country is normally a celebration. The issue of mothers going to delivery units or hospitals when they're expectant is one that is supposed to be met with celebration, not an anticipation of loss of life.
What if there was a way to reduce preventable maternal and neonatal deaths? What if we could protect the lives of both the mother and the child during pregnancy and childbirth?
It all started with a conversation on the table where we thought that we could go and learn some of the best practices in other countries and other jurisdictions on how they've been able to bring down maternal deaths and of course the child mortality rates down.
A group of obstetricians and pediatricians came together and said we need to be innovative in how we implement MPDSR in the counties so that we can start seeing a drop in the number of mothers and women who are dying.
The Intercounty Maternal and Perinatal Death Surveillance and Response Initiative is changing this narrative one life at a time.
This initiative brings together like-minded healthcare professionals, advocates, and all who are interested in bringing down maternal and newborn health.
MPDSR lies exactly as a structure under the county government health function, and that's what we thought as the Council of Governors. We need to take this MPDSR project extremely very critical.
What we intend to be able to do in that is to showcase the issues that are there, go through the figures, crunch the numbers, what is causing maternal death and prenatal issues and what we can be able to do.
This initiative is an innovative, collaborative process among Kenya's county governments aimed at ending preventable maternal and newborn deaths by strengthening implementation of the maternal perinatal death surveillance and response system. This is done through data, shared learning, accountability, and collective action.
We have actually a platform of consultation between all the 47 county governments. Our strategy basically is to ensure that Intercounty MPDSR is implemented in all the 47 county governments. We want all mothers who are actually pregnant and we lost them be audited within the first 24 hours so that we know where we missed that gap, so that we can be able to address that.
Founded and championed by frontline healthcare workers drawn from different counties, this initiative is anchored under the Council of Governors, COG, and implemented in partnership with the Ministry of Health and key development partners. Through MPDSR, counties undertake periodic reviews, identify common challenges, share best practices, generate actionable recommendations, and implement targeted interventions. From strengthening referral systems and sharing scarce life-saving resources to reduce maternal mortality, county governments have achieved notable milestones in strengthening primary healthcare systems and enhancing maternal and neonatal health, the challenges notwithstanding.
One of the successes that I want to confirm is we have very many counties, 6 to 7 months without any maternal death as a result of this initiative that we took as a Council of Governors.
Nilikuwa na miscarriage 9, lakini saa hiyo umenisaidia, niko na watoto wawili. Penye nilipelekwa theater, nilitolewa mtoto akiwa na 33 weeks na alikuwa na 900 grams. Na kutoka pale madaktari wamenisaidia juu mtoto alikuanga on off, damu inaisha, wanaweka ingine inaisha, wanaweka ingine, na kuja ameenda tena wanajaribu, anarudi yako sawa. Lakini nilifurahi, nilikuwa tu pia mimi naomba sasa mtoto wangu ako sawa, kutoka 900 grams sasa yako 1930.
Intercounty Maternal and Perinatal Death Surveillance and Response Initiative demonstrates that when counties work together, progress is not only faster but also more sustainable. Through the concerted efforts of all stakeholders, we can accelerate progress towards reducing preventable maternal and newborn deaths and achieving UHC. Let us collaborate meaningfully and innovate boldly to ensure that every mother and every newborn not only survives but also thrives.
We need the support of everyone, especially the development partners, input from the ministry and everyone else. And with that, we can be able to get it done.
Let us all join up together and be happy with the inter-county efforts to share the experiences and expertise so that we can be able to reduce this problem.
We are asking the country to support this initiative so that we are able to reduce the number of mothers and newborns that we are losing in our country.
We can share ideas, we can share data, we can come up with strategies to ensure that every newborn not only survives but thrives.
Our mantra is to ensure that there is no mother that loses life while giving life, and there is no child whose life is cut short as a result of the mother giving birth.
The Council of Governors brings you the Intercounty Maternal and Perinatal Death Surveillance and Response Initiative.
So now we have 5 minutes to go pick our tea. We come and sit with you so that we can move to the next session, where we're going to have a presentation by Katra on the overview of the Council of Governors. I know some of you just hear us on TV, on newspapers, for all the wrong and good and right reasons. So we'll have a presentation, and then after that presentation, we'll have another one by Dr. Maina. She's already here. So please let us take 5 minutes to grab our tea and then...
Kapenguria, this is the first time. Clap for Kapenguria. I think it is the funnest county, eh? You said you are a medical officer. You want to pursue what? Pediatrics. So somebody instills something in you. So you will hear many strange, because now you are with your seniors, it's also an opportunity for you to learn. Who? Mbagari. Oh. And Emily. I think this is your first, but you know COG. You don't also know COG. So we felt that this should be standard, and we keep on telling people who we are. Sometimes, like, when you hear about COG, you know it's about governors. When you hear about governors, it is about county governments. You know? When you hear about county, you think about election. Right now, I know you are thinking whether to vote for this one. Is he supporting the system? Because I know at a point sometimes when you are so frustrated, you say, we will not vote for him. So many things come through our mind. So we just felt that it's a standard way of taking through who we are. But I will be very quick, but it will also move with how the slide will move. I will talk more than concentrating on the slide. Just close this. Because we are also discussing something, it will be very consultative. When you hear about COG, what do you know about COG?
I know it is, in Kenya we have 47 counties, and in those 47 counties, each county is headed by a governor. So the Council of Governors is, it's like an organization of governors who have come together so that they can get a way of governing their councils, their counties. And apart from that, I know there are several directorates in the Council of Governors. Probably I tend to think there is also like a secretariat that lands, because the directorates, and they handle several issues that are devolved. Of course, they work in conjunction with national government.
Lakini sitakuacha, unajua wewe ndio Gen Z mmoja uko kwa room. Ni nini hajasema unataka kuongezea? Who are this Council of Governors? Personally, when I came to COG in 2018, I knew nothing about, and I came from a county, but I knew almost nothing. When I tell you my story, you will just wonder. I just wanted to move out of county and go and land, but I didn't know what it was. So, what has she not said? When you hear about Council of Governors, have you heard about us? You only know your governor. Who are we?
From my understanding, it's more like a board that unifies the 47 counties and links them together.
It's a council. Mpigeni makofi, amejaribu. Leo tutakusumbua. Nyinyi ndio mnasomaga sana, mtatuambia ile kitu hatujasema. Quickly, so Council of Governors, just the way you said, is 47 county governments. And we were actually created under Section 19 of Intergovernmental Relation Act of 2012. Najua msomagi katiba, nyinyi mnasomaga to the current guidelines of maternal and newborn care. Lakini hii lazima mjue tu. Juu ukiingia interview, hata ukienda UN unatafuta kazi utaulizwa hii. And then it is we are like an intergovernmental, 2 levels of government. We have 2 governments in this country, the national and the county government. 47 county government, 1 national government, but we are 48 governments, but 1 nation. You always say we are 48 governments. You know we are 48 governments, but we are 1 nation. And this actually speaks, they speak in one voice on all matters that is relating to devolve. Kwanza mambo na strike wanashikana, wanakuwa na 1 common position. Mkitusumbua tunawaita, tuna make 1 decision, common interest. Hivi ndio tutaenda na wanasikizana. Wezi pata mranga anasema pana mimi sitafanya hivyo. 1 common voice. And if they want, 1 governor cannot recede a resolution that was made at the council. They must come back again. If a county wants to vote, they have to do again that. But once it is a resolution that has been passed, it has to be there. This is our vision, this is our core value. You can move the slide quickly, they can check this on our website. This is our mandate. I said we are stipulated under IGRA, but this is what we do. We facilitate, we capacity build. We have secretariats, just the way you say, on all the functions that have been devolved. So the people who have just convened you here are the Council of Governors Secretariat of Health Directorate. Any matters to do with health, we convene as a directorate, but there's a structure. We have governance structure. We have the CEO, Council of Governors. We have the executive of the council. We have the chairperson of the Council of Governors. And we also have the deputy governor. And then we have deputy chair. And then we have the whip. Who is the current chair of Council of Governors? Mudhomi Njuki, because he comes from Machakos. Just say pass. Who is the current chair of the council? You got lazima tuachanue. Pass. Pass. Who is the current chair of the Council of Governors?
I think Governor of Wajir.
Governor of Wajir. Governor Ahmed Abdullah is the chair of the Council of Governors. He is the one who convened all the 46 governors. Who is the vice chair?
I think the governor for Mudhomi Njuki.
Mudhomi Njuki is the vice chair of the Council of Governors. Mpigeni makofi. Who is the whip?
Pass.
Sasa zero ni kuzalisha tu mama. The current whip is governor of Baringo County. Cheboy is the whip. He's the one who whips them to come to a meeting. But chair of the Abdullahi, and then we have Governor Mudhomi. Governor Mudhomi before was health committee chair, but now he's in the executive of the council, right? And then we have the CEO, who is the CEO. Our CEO now is answerable to the executive. Us, we have 3 directors at the council. The directors report to the CEO, but we also have head of department who reports to the directorate. So that is a structure at the council, but we have 18 committees. In the 18 committees, all the 18 committees are chaired by a governor. Who is the current chair of health committee?
The governor of Mombasa County.
Mpigeni makofi. Anything to do with health matters in this country right now, the person who is in charge of health is Governor Abdul Samad from Mombasa County. Hii ndio ile 18 committees. Hii yote imekuwa function. Kuna zenye tunakoshia na national government, but zingine ziko devolve. And then health committee inakaa hivi. We consider all matters relating to health. Kama leo nishasoma gazeti ya leo. Kama kuna issue na health, nishapiga alert. Najua what I need to do as director of health. So the governors don't wait for you to tell them, let me refer. When they call you, you must give updates. So we are very aggressive, we are ahead of ourselves. That is how we work. We are the ones who advise, who do technical advice on all matters of health. Kama ni mambo na SHA, kama ni mambo na asubuhi ukiamka lazima kuna shida tu na SHA. Asubuhi ukiamka lazima tu kuna strike. Asubuhi ukiamka lazima hakuna shida tu ni mingi. But we alert the chair, and the chair now convenes the health committee. So katika 18 committees wanaonyeshaga wale wanapenda kujoin health wanajoin. Kama sasa health committee yetu ni 18 governors. Tuko na chair lakini tuko na 18 governors na Wanga ndio the vice chair. In the absence of Governor Abdul Samad, she chairs. I will talk off the cuff because I know all these things. The slide has to move. This is at the directorate level. Remember, health has a building block. Under each health building block, we put the CECs to be part of the technical working group together with the national government, because we have health sector forums that are supposed to happen every after 3 to 6 months. So we plan with the national government. So kuna a whole committee on human resource service delivery, health information, health product, na inakuwa chaired na mawaziri wa counties. We have 47 waziris in the counties, and we have chief officers 47, and we have directors. Wote wako na kazi yao. Director ndio technical advisor to the executive. Tuko pamoja? But CEC ndio ana respond to, he is answerable to the governor. He's the one who give him advice. But the chief officer, their work is just accounting, human resource, anything to do with accountability, like they're the PSS in the county. So all these things now we work in collaboration. So ukiangalia, we can be able to share with you when there is a matter on service delivery, like there is a committee from the counties together with the national government. So before we go to health sector forums, anything that we can unlock, we unlock at technically, but then if there is something that we cannot unlock, we take it to the health sector forum. Health sector forum, you are also free to join. You can listen in virtually, you can come physically. Just get in and, let us hear your voices. Because that is where now Duale and the chair of health committee chairs. That is a place where now we need to make decisions when things are not working at the technical level. And I think in the health sector forum next, the upcoming one, we are planning, we need to push the issue of commodities, basic commodities, and something on maternal and newborn health under service delivery. When you hear about fourth schedule, it is the constitution. It will just tell you what's the function of national government, what's the function of council of governors. So most of that time when you see there is fireworks between the two levels of government is because of clawing back functions. You are managing functions that doesn't belong to you. So I will not go on to all this. You all know this. For example, just go back. When you look at Schedule 4, these are the functions. These are the functions now assigned to the county government. Lazima ujue, ndio usiende kufanya vitu zako. Kama sasa, ukisikia health facilities na pharmacies, hiyo ni kazi yenu. Ambulance services, it is the mandate of county government. Promotion of primary health care, licensing and control undertaking. That is why now you guys, as you sit here, even when you have a maternal death in private facility, and they are referring to, you have all this, you have all say to go and close down that facility. It is the mandate of the county government. If something is, because you are the one who is oversighting all service delivery, whether it is private, whether it is health. If there is a facility that is referring to bad cases from a private, you need to write a letter to the MedSup, and then it goes to the county headquarters. They'll have to go and close down that facility. It is their mandate. They're the one who have oversight role, both in private and in faith-based. Then this veterinary cemetery, muliona siku ile Langata ilijaa. National government walienda walisema ifunge. That's not their mandate. This is the mandate of county government. Cemeteries, funerals, all these things. But it is also a public health function. So you know that? We actually convened a meeting with public health officers from Nairobi County. They were telling us many things and we were like, what? Because they were telling us if the cemeteries, the way it is full now, bodies are like unazika body on top of another body. And then the toxins and the what, ukona boho lapo karibu. Guy, we were thinking of many things. Sometimes, when you hear things is when now you wake up and start rolling sleeves. So all these are the functions of county government, but you'll be able to see this through Schedule 4. You have to move the slide quickly. What are the sources of finance for health? Where do we get money? Zebu, just close that thing. When you have a problem, do you know how much budget you have for your pediatric? You are not a manager.
From my department. Yes. Right now I'm at around 3 million per month.
How much do you get? You generate 3 million.
Told.
How much do you generate?
SHA is not reimbursing.
SHA is not reimbursing. How much money do you get for your department? You are a manager. If you are an obstetrician and gynecologist, in government we have hierarchy. Who is the topmost in the hierarchy? We have an MO and then we have obs and gyne and then pediatricians. How is the hierarchy look like? If you are a consultant, you are a manager. If you are a consultant, you cannot go on strike, you are a manager. You can't join MOs on the street, you can't. You are a manager. You are a head of department. And that is why you guys, I'm telling you, you need to walk out of your comfort zone. You must know as head of that department, how much have you generated, and when the health management team sat, how much was given back to your department. Unafanya how many surgeries?
70 in a month.
70 in a month. 70 in a month, one delivery costs how much?
30,000.
30,000. That is for CS. For normal delivery?
15.
Calculate for me that. Calculate for me that money. We must talk to each other, by the way. We are moving from the issue of passive to action. If you are aggressive, you will achieve. If you are not aggressive and you let everything go, you will not. You are the senior most. You can pull a chair, sit in the HMT, write papers, and tell them, this is the amount of money that I generated this month, and I don't have kabetos. Hiyo ni pesa ngapi?
It's 2.1.
2.1 million for cesarean section per month. Ulipata pesa ngapi this month? Sijui. Is it a healthy discussion? Is it a healthy discussion? You must know in your department how much you are generating. And what you are generating, if I have done, for example, today, I'm calling a Grace, she's telling me, director, nitajoin mkutano, niko na 5 CS. So me already najua nisha calculate ameingiza ngapi. So wewe pia, lazima every month, the HMT sit, the health management team sit, and they make decisions. So budgets are coming from the departments. And I remember I used to be a nursing officer in charge. All the nursing budget, I'm the one who actually put in the budget. If I don't see maternity telling me I need this, that is gone. So then that means you must sit with the department in charge. You must work as head of that department. You work with the nursing manager in that, come up with your budget. Then you must know from the resolution how much have they given you back to maternity. Otherwise, you can't just leave up. You tell me I've worked, and you have 0 shillings that has come back to your department. You are doing 0. And that's what I'm saying. In this meeting, we are not going to complain. Na wachanua tu kidogo, unajua sisi ni healthcare workers, eh? Mara zingine, unasema tu niko na 8 hours, I do my part and I go. But you do your part, you left, but you will come and find problem. I joined one of Intercounty MPDSR, I will not say which meeting. A mother worked with oxygen level of 50. Inaitwa 50 millimoles per liter. 50%. She was dyspneic. She was pregnant. The only facility that will save her is the next facility. She walked into that facility. She arrived on time. The oxygen cylinder was empty. Who killed that mother? Who killed that mother? Even if you are a consultant and that's not your work, but remember the mortality will be audited in your department. There are things that you check. If you can agree with me, the work of the nurse manager in the morning is to come. That is why you have matron in a facility. The work of the matron is to ensure when she receives reports, everything that is required within that department is there. You must have meetings at 7:30 a.m. What is it that we have? What is it that we don't have? I know you are busy, but work starts at 8. Silio, you can even go 7 a.m., have frequent departmental meeting. Then cover your back, do a report. In this department, we are seeing we don't have this, we have not seen this, we don't have this. In this week, we killed 2 mothers. If this does not change, we'll put down our tools. Things will work for you. You don't shout alone, shout with others. Will they remove everybody? I'm just giving you tactics, but I'm not saying go do that. I'm just giving you, I'm just instilling something on you that can work for you. You have to be very brave because it is not about your interest. It's you about giving quality of care. It is you to make the environment better. If you don't win the heart of your leaders, then you may not achieve. If you are somebody who complains from morning to evening, they know, yule tena ametuandikia. But move from passive to action. Hapo ndio unapata pesa, and you can calculate the amount of money you get in your department. You can task. You can tell the matron in that department, if this money is not coming back, we will stop delivering. On-source revenue, facility improvement financing, there is SHA, teenage pregnancy mothers, on the size they have free cover. So, but if you see them and you don't report, you don't get that money. That's lost money. Then donation, and then FBOs and the rest. These are source of income. But you can also, as Grace, you can look for your other partners out of the hospital network. We will work directly with you. Right now, Directorate, I think maybe you can just check the last 1 year, how much money did we resource mobilize as Directorate of Health? And that is what is even bringing us here. We look for partners. They don't look for us. But when a partner sees a value in you, they'll instill to another partner. You find like this week. Last week I got new partners. All are interested in Intercounty MPDSR. And they want to get funding. But we have to guide them on what you want. Maybe you can just calculate so that they know as much as you have that responsibility, you also need to walk out of your comfort zone. Right now you have Charles. Charles, I know you moved from JPEGO, now you are in IHRK. You are being poached from one partner to the other. And already you have a good relationship with Minor. You can sneak to one number and IHRK, you have this amount of, there's this. Can you just write a proposal? Hitherto. So you also, when you are in a position with a partner, you have to steal for us something. You have to connect, guys. If, for example, something is working for you and you got some money from a fund, somebody, a partner, then that person should also link you up. Mimi pia nimepata like 3 million ya commodities na wewe ebu wajaribu. That is how network works. That is how I generate money for my department. Maybe how much have we generated the last 1 year?
So for the counties, overall, we were able to negotiate monies worth, whereas is 3 billion for the counties. That one is money going directly to the counties. And also we have Beginnings Fund, which is also giving us money, about 12 billion to the counties for 5 years. Then we also have SBTF that is supporting counties, about 9 billion. We also have, we even have smaller ones, less than $1 billion for the counties we also have. So at COG, in that common goal of looking for the interests of the county governments, we also do research mobilization for county-specific projects with the monies going directly to the counties. And you will hear some of them in her presentation.
But those lives, as we save, we also need resources to save those lives. So you can even schedule in a week, like, do you have departmental meetings? In the departmental meetings, you can just, one of the components is like how much have we generated and how much have come to us and what is the gap. Then as head of department, you just write official letter to the MEDSUB. You've covered your back. If you complain verbally, nobody will listen to you. You go see him, seek an audience, but you must do an email or a letter to the head of that facility. You can copy the CEC. Nobody will stop you from doing that because it's more on service delivery. So these are successes under our directorate. You can just see, you all know that the last KDHS things that we haven't done, like the MMR was not there. But for skill deliveries, we were at 89%. But right now, from 2022 to date, our skill delivery has gone down. And we are doing a report on analysis from SHA. Most of the, what has really contributed to skill delivery going down is the SHA. You know, we used to have walking and a Linda Mama. Now we don't have. So because of financial barrier, many patients are not accessing the health facilities. They have gone back to the TBAs. And I know, like, we had a case for Nairobi. I think they were telling us they have gone back from 100% to 60. Something like that. I'm not so sure. But they have significantly gone down in terms of skill delivery. So we have things that are happening that we need to work on. Immunization, all this, right now we don't need to say where we are. But also under AMREF project, we were able to train. And like we said, facilities must have autonomy. You generate money, you use that money at source, but then it has to follow the accountability structure. Then we have the NIDA program for level 2s and level 3s, but it is also coming to an end this year. But I know there's a new project that they are deciding. What are our key achievements? We do a lot of coordination. MMR has been one of our biggest achievements the last 9 months. Everybody, including a clerk, wanakuja wanasema tuongeze kwa hiyo intercounty yenu. Even if they can't use MPDSR, tuongezeni kwa hiyo intercounty yenu. And yesterday I was hearing, neighbor was telling me, the procurement people, because we are doing procurement, we have series of events, the procurement head was telling his team, mukiona tu anything imeandikwa MPDSR, approve tu iende kwa finance. Because if like nikipata tu shortfall kidogo hivi, I'm in the CEO's office. And because I've also instilled the passion in the CEO, she will start making, so like memo zangu hazisimami, zina move. Na pesa inatoka wapi? Kutoka directorate yetu. So ile bottlenecks ati unaenda kwa finance, ambia leta hapana. We don't work like that. So that's what I'm saying. Occupy, you guys are very powerful. As much as you're doing clinical, also see what amount of money that you require for your department. By the way, do you budget in your department? But the budget, do you get approval for monies? So what have you done? I'm challenging you. Next. Some of these, all these are just achievements, documentation of best practices. If you go to our Marifa platform, you see a lot of documentation. And please make sure, because you're a champion, give us a story. I think the last story we documented on Intercounty MPDSR, right now we want to document one on Kilifi and Tana River, we were there, but I saw something on PPH from Kiambu. You wrote to us. Yeah, and when you write to us, we assume that it has been validated at the county. We can't upload into the Marifa until we get the validation from the county. So by the time you write to us and tell us, please let it not only be counties, even a referral hospital, you can write to us something, a good story about a perinatal something, just something innovation. You know, we said we don't have boundary. Probably what has worked for you in that department will work for another county. So it is you now to go. Maybe I can seek audience with your CEO. We see how we can be able to collaborate so that you have that avenue of giving us information so that we share on our Marifa platform. It is only us who have. And there are a lot of information on our website. So because of now the peer-to-peer learning, if you do something nice at Mama Lucy, give us the story. We will document for you. And I know we have many stories from many counties that we've uploaded. So next.
With my colleague, Dr. Celia there. And I am also the National Secretary for Association of Muslim Medical Professionals in Kenya. So we hope to disseminate this good progress both at facility, county, and nationwide level. And even though Director did not ask me for my targets, but one of my targets is to create working linkages with nearby facilities, because you know what we go through as Mama Lucy Kibaki Hospital, and also hopefully to introduce a referring checklist that will be able to assist us in reducing unnecessary referrals. Thank you.
Good morning, everyone. I'm Amina Mohammed, obstetrician gynecologist, the head of HOD for obstetrics and gyne department in Garissa, Level 5 Hospital. Yes, I'm glad to be here. And Katra, you didn't ask me about my target. I have many. I don't have two. So the most important one is how do we do mentorship and to visit the sub-county hospitals, including us. We are mainly affected by the refugee, the Dadaab refugee. And since they have issues with funds a bit, there is some issues a lot, yeah? And most of them, they bring us very sick patients. If we want to refer them to the national levels, they usually say they don't have funds for that. And hope one of the things will help us will be that one. The second. Okay. So we should start working now. Inshallah. Okay. Thank you very much.
Okay, thanks, Dr. Amina. President, two-term. By the way, she was re-elected last week. I was there. I witnessed.
So I think it's just about to turn afternoon. So good morning. Good morning. Okay. Yeah, I sat here so that I do not interrupt the presentation. And my apologies for coming in at that hour. My name, for maybe those who are new, is Dr. Super Tunje. I'm a pediatrician and a neurologist. I practice at Machakos. So you are within my county right now. This is Machakos County, and it is a pleasure to always be part of this conversation. And okay, you already said I'm the president of Kenya Pediatric Association, and my first target in joining this was to actually get as many pediatricians to become advocates for children. And I think partly that has been achieved. A lot more, and you will keep seeing more and more of them joining. And I can assure you, Mary, Amenge, Katra there are very many of us that are doing as much. Sometimes it seems that we are not getting results, but I believe that in the small gains are going to accrue to a bigger impact. So I'm really looking forward to seeing this becoming impactful. For us in pediatrics, we want to get where the mothers are, where you're counting one death in a month or in a year or in months. It's not the same situation for babies. So we are working extra hard to get to the targets. Thank you.
Thank you, everyone. I don't have a presentation, but for the sake of those who are joining us for the first time, just quickly tell us who Intercounty MPDSR is, just an overview of who we are, what we do, what we've been doing. And I'm so grateful to see Mom here. She's Linda's mom, and when you see people coming back from retirement, it means that there's something you're doing right, that you're pulling people back from retirement to actually be part of this. Super, this is Dr. Has retired, worked in Gertrude's for many, many years. So she's been very interested in the work Linda has been doing, and she says she wants to be part of it. She's actually going to Tana River with us. She's on the list. She said she wants to come. So it just means that, as she said in her introduction, that things they wished would happen are finally happening, and we are happy to be part of that journey. So the Intercounty MPDSR initiative started in June 2024, and it was informed by an experience we had between Kiambu County Referral Hospital and Kenyatta, where we were able to discuss every referral that left Kiambu Level 5 Hospital to Kenyatta with a team led by Dr. Menge, because he leads the MPDSR work there. So we were able to get feedback every patient that we referred for close to a year. So we could actually account for anybody who had left our facility. Whenever there was a mortality, we would actually, even before we started these joint reviews, we would actually review them together. And out of that, we realized we were both experiencing the same challenges and frustrations with referrals. So when we started, our idea was actually to have consultant doctors get more actively involved in MPDSR because we were missing. The truth is that we were missing. You would have a mortality, leave the intern and the midwife to be the ones breaking the bad news to the family and to be the ones leading the reviews. At some point, MPDSR, people would avoid MPDSR reviews because we know how the counties used to come and blame health workers for anything that went wrong. In fact, I remember in our very first meeting, Dr. Muviko, who was at the base facility, said that she actually stopped attending because the county team come to bash them for anything that went wrong. So she said, I actually stopped going for those meetings. So we wanted to change that story. Number one, to have consultants more involved. And number two, to coordinate referrals around the Nairobi metropolitan counties. So we started in 5 counties: Kiambu, Machakos, Murang'a, Kajiado, and Nairobi. So we were able to come together initially as obstetricians, then pediatricians later followed, led by Dr. Supa, Mudhoni, and Manyasi. And the story morphed into something totally different. That's why you have anesthesiologists here, you have midwives here, you have neonatal nurses here. AMREF came through for us initially. When you're starting something, one of the lessons we've learned is people don't believe in you. Yeah? So we would go borrowing people money for a meeting. No one believes in you, you know. So AMREF actually believed in us, and Dr. Chris Barasa was very instrumental. He was the first person who held our. So he would pay for our conferencing, but we used to use our own resources. From our own pocket. Kina Madeka would come from Machakos with Supa, Salma from Kajiado. So we'd use our own resources. And a conversation started. So we went to COG last year in February. And I think that was one of the best decisions we ever made. Because we realized our frustrations are in the counties. Nobody is listening to us. So you would sit in MPDSR meetings, make the same recommendations every time. As in the same thing you said last year is the same thing you're saying now. So we just made, we didn't even know who they are, by the way. We didn't know, we had no idea. We just sent an email, and the following day, Charity, I remember Charity calling me the following day, and I was shaking because I could see from Truecaller it's somebody from COG. And she said, this is in less than 24 hours of the email. She said, Director said she'd like to see you guys tomorrow. And I'm like, Director, we don't work like that. Maybe we have, someone has a theater duty. They said, no. We have scheduled a meeting for you guys on Tuesday morning. So we're able to put a few people together. Kina Wayego, I think there was even a COGS conference ongoing that time. So the obstetricians were not there. So majority of the people who came were actually pediatricians. So we went and we were received very well. We were scared because we saw they came with a lawyer. Director brought a lawyer to the meeting. So we thought they were coming to tell us the Constitution does not have any word like intercounty in it. So our project is dead on arrival. But the opposite actually happened. So that's how our journey with COG started. And I think the next turning point was the Devolution Conference side event. So when DevCon happened in August, COG people, Sheila is not here to tell that story that she usually tells of how we applied to host a side event. We didn't even have a single shilling. And we were supposed to pay 500,000 shillings for that event. We didn't have money. We kept asking partners, supporters. No one was supporting us. So we still applied. Eventually, courtesy of... So they thought it was PS Mweri Mudhoni who was holding a side event. But to cut the long story short, and grateful to Dr. Wangoi Muvigani and Dr. Laura, who are not here. They did a lot of work behind the scenes. They were able to get somebody to pay 300,000 shillings for the side event, but then we had a balance of 200,000. The deadline had passed. It was like a week after the deadline. And director here, maybe now people will know you, played a very cute, I have never said this before. I usually say there is someone who helped us. So one morning, director calls me and tells me the CEO and the chair of the health committee are in the same meeting. Kuja ujitetee hiyo 200K. I was actually in the clinic. I left a patient in the clinic, took an Uber and told that Uber I have to be in Westlands in the next 20 minutes. So I found Governor Mudhomi, who was then the chair, and the CEO. In fact, I was running after the CEO on the corridors. And they were in another meeting with Indians. So I crashed into that meeting. And after like 30 minutes, the governor said, there's someone who has not spoken in this meeting. So, and I'm like, I don't even have an idea what they are talking about. So director told him that I was there for a different agenda and he'd give me audience after the meeting. The CEO left in the middle, so I had to run after her and convince her that we need a waiver of the 200,000 shillings, which they both gladly did. And I think that side event accelerated all the efforts that we had previously made, and MPDSR became a national conversation. So why are we here? We are here because we are a group of people who got tired of saying the same things every time. People who could not access their governors. People who could not access their leaders. CHMT does not attend your MPDSR meeting. So you're basically talking to yourselves. And that's the bridge, that's the gap we wanted to bridge as frontline health workers. This work is voluntary, by the way. Hakunaga pesa. There is no money. If anything, you actually lose more because you would be doing cesarean sections, you know, and receiving babies and getting your 30,000 per baby. Kupanguza tu hivi mtoto hivyo mna pediatrician unapanguza mtoto, you give us a bill of 40,000. But you leave that because there's something bigger in you that drives you. And that's why you see sometimes we are not keen to just add people to the group because they're obstetricians or pediatricians or RH coordinators. You must be driven by something. I'm happy to meet Marigi finally. Amenge always used to speak about her. She's like, there's a midwife in our labor who keeps asking us why we are not adding her to the group. And those are the people we want. You know, people who want to be in the group, people who want to do the work, because it's a lot of work. It actually sometimes feels like a full-time job. Yesterday, COG was blowing my phone and Amenge's phone. And they reported us to director that we are not picking our calls. We are not responding to their emails. So it becomes like actually a full-time job because you have an agreement that we are having this meeting. You have a clinic to run or a theater to run. There are things they need from us. We are not giving them in good time, so we are frustrating them also. So it actually is a full-time job, but we are happy to do the job. We are happy to see new faces. The MO from West Pokot, when I reached out to the obstetrician there, he's like, I can't come because my colleague is on leave, but I have a very young, passionate, energetic doctor I would like to send. So we are happy to see you guys coming up. Sisi tukizeeka, ni nyinyi tunawaachia. All right? You know us now with menopause, we slow down a little. So we are happy to see younger people coming up. And as I said, the work is largely voluntary. We hope one day it will finally pay us. But when that mother who nearly dies survives, or that mother who's lost 2 other babies at the point of delivery finally takes a baby home, they go and say a prayer for you every day and say, God bless the doctors who saved my baby's life. God bless the doctors who saved my wife's life. So when your practice thrives or other things are working well, your children go to school and they are the top students, don't think it happens by chance. It happens because there's a family somewhere that says a good prayer for you. So I hope for those of you who are new, we'll walk this journey together. Salim Amenge has been lonely. As you can see, boy child is a problem. There's a problem. So we've been looking for a brother to work with Amenge, and I am happy to see you consistently for the last few meetings. You've actually showed up. So we are happy to have you. Let us have a male involvement. Sijana ilikuwa male involvement. So we are happy to see the men, pull a few other men who are passionate about the work. And we see where this goes. So thank you very much, everybody. That's just a brief summary of who we are, what we do, what we hope to achieve. We now hope that in the next few months, as Charles comes up to present, we can actually form teams that are focusing on the top killers of mothers and newborns. We give Wayego a job to say that I am going to pick people from different counties to come up with initiatives on how to reduce neonatal sepsis. Then we have another team that is working on postpartum hemorrhage, etc., etc. Because if we keep doing the same things we've been doing for a long time as a country, we'll keep saying we have stagnated. And those of us who are tired of stagnating and don't mind getting out of that comfort that we are used to just do things differently. So thank you very much. I've actually finished, Elliot. Thank you very much. Clap for me, please.
Thank you so much, Dr. Maina. Are we all at par in terms of understanding how this came to be? Are you proud of the progress? So far, so good, yeah? And the sky is not the limit for us. As we say that this is our unique, and I think I'm a bit hesitant to say the magic bullet that will work for Kenya, but time will tell. Time will tell how we do it, how we implement, because ideally why we are stagnated is because the surveillance or the data has not informed the response. Now we want to move to a place where the surveillance, the reports improves the response, so that the reason why the last mother died becomes the reason why the next mother who would have died does not die. You understand what I'm saying? Such that we need to move to a place where we act on what was done. And therefore we are shifting, we are actually shifting the accountability, or rather sharing the accountability, including all the actors in it, because we have the clinical part, and we have the governance part, we have the financing part. All these things need to work in a complementary manner. So at this point, I want to invite the director to come and share. No, let us stand up. We do the cuckoo dance first. We warm up ourselves, cheer up, and then we'll have a presentation that will just give us a highlight of, since we began, what have we been able to achieve, where are we at, what are our next plans, and how do we get where we want to go. So it's now time for cuckoo dance. Everyone be up. Up. baadaye. We'll do this one. We will do this one after lunch, yeah? Thank you so much. I know you now feel different. So, yeah, so this is going to be the next presentation. Let's see what we have done since we launched the investment case, the MPDSR investment case. What we have done since we have had several MPDSR meetings. We have had county visits on this topic. We have had webinars addressing matters pertaining to this. So this is like a progress update on what we have done so far. And then after that, we'll be able to see what we need to prioritize for the upcoming months. So Director, you're welcome.
Are we together? This mic is dead. Do these people know that we are paying for this service? Am I audible? I have a request. If you can shut down our laptops and if you can put down our phones. It is hard for a speaker to be speaking to himself. And there is no way a two-term president can sit behind others. The leaders always sit in front. It is in government protocol. I haven't said that by myself. So Supatunje, come and look for somewhere to sit. You can't sit behind us. So quickly, the way we've said, I think I've already said in my presentation that we started a journey that now is giving us results. And in leadership, you must take stock of where you are, what you've achieved. If you are a leader and you've put interventions and measures in place, you must pause and reflect on what you've basically done. Is it bearing any fruit? If it is not, you need to reflect and re-strategize. That is leadership. If probably you have targets, just the way we ask, what is your target? And you have a target, you've given yourself time frame. A good target should be very smart. It should be very specific, it should be very measurable, it should be attainable and time bound. That is a smart target. It's a smart target. If your target does not have time bound, it's not a smart target. So if you've done something and within probably 3 months, not showing progress, you have to change the strategy because that strategy is not working for you. Do we do that? Ama munaingia theater una scrub, hakuna sabuni, umepiga kelele ukaletewa, ukapata sabuni, ukascrub, ukaingia, ukazalisha, hakuna kabeto sinu, ukapiga kelele, ukamaliza, mama ameseviwa, ukastruggle, ukatupa. We used to say doctors when they finish procedure, as nurses used to feel very bitter. Like you remove the gloves, you put it on top of the table and you go. So all the staffs remain with the nurses. So we used to complain. I think it has changed. I hope it has changed. That is what doctors used to do to us. But you see, those times it is one doctor to a doctor. The same doctor is a PMO. The same doctor is a medsup. The same doctor is a provisional medical officer. So umemwita kutoka kazi ofisi, atakufanyia CS, anakuachia hapa juu gloves ya ameenda. Si ndio tuna scrub, tunatoa zile mabakio. It used to work like that. But right now, I think even the system that we used to work in has changed. During our time, we had a lot of difficulties, but we saved mothers in that. We did our best. We gave our best. We gave our best. But right now, even, like the way even human resource has improved, recruitment has improved, systems have improved, the problems have become more. I think we also are producing county, a country, see? We are very productive. So the population is not meeting the needs, what do we say? Like now, for example, we have not met WHO standards up to now. See? But if you look at progressively, if you look at how the recruitments and everything is happening, something is happening. But we are not achieving. What is it that we need to get right? So I'm bringing all this because we had a commitment as council and as Intercounty MPDSR. And I said, we must deliver because we've made commitment. And the commitment must show results. If you are sitting in an audit and you are repeating the same complaints, that means that audit is becoming useless. If you've discussed in an audit, there was no oxygen, you lost a patient. Then in the next audit, you are talking about the same oxygen and you lost it. That audit has no value. In your next audit, you said, I need the people who are supposed to fix for me this system. But don't get fatigued. You write officially to your leadership that we've had this audit, this has happened, and in the next audit, we want your audience. The leadership also, when you are scoring at the technical level, they are also scoring as leadership. You know that? And then the governor overall is also achieving. So we must talk to each other. And that's why we are saying we move from passive to active. So never give up. Never. Me personally, I don't give up easily. By the time Katra has given up, like I'm in hospital bed, otherwise, I will not give up. I'll give it my best. I will talk, but at the end of the day, somebody will listen. So this is just update on the initiative. We had county-led peer learning, joint problem solving and advocacy platform. I think you all know that we have a forum. This was established in 2024 by the pediatricians, obstetricians, midwives are there. Initially, we started with 5 counties, but right now we have all the 47 counties onboarded. We had a lot of challenge, but finally, I know the 5 counties have brought on board the other 42 counties, including national referral facilities. This has basically now gone into a national platform. Even you see vibrance now, even the Ministry of Health are trying to train the guidelines, things are being disseminated. There are so many webinars. All of us now are on board. I think we just woke up and realized things are not good. And us being in leadership, we must be held accountable. We must talk to each other. So in response to a critical gap, many maternal and newborn deaths involve referral across the county borders. I think you've heard, as much as we have inter-county referral, we also have border counties referring to the country. I think, is it Taita Taveta? They have texted me of 2 cases. They got bad cases from Tanzania. And they ended up being a mortality. So I'm like, now where do I start? I don't even know the president of Tanzania. How can I access? But I think I guided and I shared with our chair of health committee that he need to get audience from the CS Health so that we can be able to write officially to the government of Kenya, can write to the government of, so that as they refer, because we are sharing boundaries, we can audit that death together. And I think maybe Charity, you can put for me that one. I know I haven't followed it up, but I'll need to follow up that one. And then we need also to create structured mechanism across county learning, joint case escalation of systemic issues and as such. And I think something is already happening. I told you, right now the MNCA champions that we have, if they have a problem, they have my number. They tell me, this Homa Bay have referred to us a very bad case. Now we ended up having mortality. And it is not ours, it is theirs. So counties are feeling pain. That is just an example. Homa Bay is just an example. Counties are feeling pain of carrying the burden of another county, which ends up into increasing their mortality within the county. But I know that is actually a good gesture of fast-tracking everything that is happening and even giving feedback to the county that has referred. So these are some of the key achievements. I think I've spoken about the investment case. This investment case was not developed by us. It was developed by us seated here. And I felt that if it comes from you, you own it and you will be able to implement it. Then we have, this has served as a strategic anchor for the initiative, providing framework and time, priority interventions and the rest. And it also guides the council's work plan. Now this is the investment case that is also guiding our work plan, because we need to get the priority areas that are achievable. If you set yourself a high target that you cannot achieve, then that is just redundancy. You must sit down and say, can we achieve this? Can we achieve this? And by the way, I always keep on saying, not every intervention will require resources. There are soft interventions that can happen at your level. There's a county that lost many mothers. And a team of leadership just walked into that counties. And all of a sudden, without resources, things started happening. That county stayed even for 4 months without losing. Yet in 2 months, they lost over 18 mothers. Accountability. It's about accountability, right? So this is what is actually guiding us. Also, when we call you here, already it is part of the investment plan. We need to vibe, we need to talk to each other, we need to see what is not working. Like, we need to get more and more update. Probably even now, like, we are in an engagement for, I think, close to 9 months, if I'm not wrong. Like, do you see value for COG? Or even us will ask you, like, what added value did you give us? Because we told you, we trained you, we told you this, we unlocked things for you. So what have you achieved? So we need to ask ourselves hard questions. We will ask ourselves hard questions. Are we really doing what the frontline healthcare workers expect from us? We will also ask you, are you giving us results for the support that we are giving you? Those are conversations that we need to have, and it doesn't need to delay. I think every 3 months we can be able to take stock, come together, review, and see whether we are progressing or whether we are not progressing. So these are the pillars in the investment case. I know the consultant will take you through. And then next is about, I remember when we developed this investment case, one of the things that we haven't achieved, but I know we will achieve in the next 3 months, is we were to have a costed investment plan. This one is not yet costed, but we need to break it down. What is the priority? How much will it cost us? And I remember we said we are going to bring on board all the partners who are in this space so that they pick on a component. And it is in the spirit of all the 47. It has nothing to do with counties that have high burden, no. Because the counties that have high burden are the counties that are causing all the 47 county governments to be onboarded in one forum. If we will have gone specifically, it will have been an issue. But right now, as much as we are doing targeted intervention, we need to have 47 champions in one room, seeing how we can be able to think together and change the figures. And that is why now we have all the partners. Because one of the other things is mapping the partners that are in this space who are really also willing to help. So we must have a costed investment plan, which we don't have. And I said next week we are going to have a meeting, a very high-level meeting, and we need to basically project that to them and tell them this is our priority for the next 1 year, for example. So these are also part of the achievement. Who has never joined our webinar? Just be honest. So far, I think we have 6. 6, we are having another one on 30th. One of our commitments is we said we must have webinars. It will be a governance webinar and a technical webinar. The one that we are having on 30th is governance. We are having 2 governors. We are having the CS. We are having also other sectors, private. And we want to talk about babies, giving birth to babies. It's a headache. So what is the country conversation? What do we want to say? Because these are also a population that is contributing to maternal death. Right? So we need to get it right. We need to like hotspot, or we need to target the spots that is giving us these mortalities. We must. You must. Unajua ukitaka kuua nyoka, unaanzia wapi? Unaanzia wapi? Muranga amesema unaanzia miguu. Ukigonga miguu si kichwa tu bado inatembea inaona. So you must target the source. You must target the source. It's like if you get a bleeding mother bleeding, will you start complaining about there is no gloves, or you already have a gauze? You immediately stop the bleeding. The immediate thing is stop the bleeding. Sindio? So you don't need to complain and say, you know, these officers are not giving us sterile gauze, we don't have, and the mother is bleeding. You do the immediate and then you do the other things later. So we must target the spots that is contributing to giving us this whether it is babies, whether it is. Yesterday I was in another meeting. Our ANC visit for like those who access fourth visits, we are at 74%. Mothers are coming to ANC, even the 74% that access the fourth antenatal care, they don't come to the hospitals and deliver. Why are mothers running away from the hospital?
Oh,
You know
okay.
she's the first neonatologist in this country. Do you know that?
Okay.
But why are mothers refusing to go to the hospital to deliver?
Okay.
I know you are in Gertrude's,
Mhm.
but in the public, maybe Nandi can tell us, but in the private, you also have the same problem.
Before I went to Gertrude's, I was working in the Kenyatta National Hospital. So I know both sides of the coin. So there's nothing new about private and so I think one of the biggest problem we're having with the mothers not going to deliver in hospitals, one of the challenges, as you said, about the drop because of Linda Mama and the current SHA. There's been a lot of uncertainties as far as SHA deliveries are concerned. Hospitals are not sure. So as much as SHA is working on paper, when mothers go to the site, there is a lot of referrals. So you go to one hospital, SHA is not working. The next one. By the time you get to the other one, either you do it on the street or you go back to your TBA. So I think that is one of the biggest reasons, because as we know, it is very difficult for mothers when they go to hospital to be carrying money, especially in the rural areas. It is an emergency. So,
But remember, at night, many things happen at night. Mother goes into labor at night. There are no vehicles at night. Your relative will not pick your phone because the phone is off. And then, when you're struggling, it is morning. By the time you pick our hospital, it is already the hospital.
yes.
Senior?
So I say actually that part of financing is one of the reasons. So it's not like a big magic.
Basically, it is a financial barrier. Sindio, why do mothers prefer TBA? You have Maina in theater. You have my sister from KNH waiting for the baby in KNH, a neonatal ward. But I've gone to TBA. Why do mothers prefer TBA?
If I may speak from the context of Kajiado, our skilled deliveries, we are at 80%. That shows that 20% of our women are delivering at home. Reason, it's multifactorial, but for the TBAs you've talked about, is about how they talk to them. They really know how to talk to these women. By the time you're starting your labor all the way to delivery, they kinda even ease your labor in terms of pain management. So at times even our attitude to the way we treat these women is why they're running away from us.
Is it true? When I go to TBA, she'll massage my back. She'll give me a hot cup of coffee or tea. She will have all kind of oils to massage me, maftanazi and everything. She will lift my head up. When I deliver, she'll give me hot shower. But when I come to your maternity, you have delivered 3 mothers, and this one walks in. So unasema, mama angalia kama kuna kitanda iko hapa na nafasi tu upande nitakuja kukuona. But you see, it is not about you, sindio? That is why we are also talking about HRH gap, sindio? But I know right now we are trying to fix the system as much as possible. I always say, even when I was practicing, please, for you to attract a patient to your hospital, just do a facelift. So that even when I walk into that facility, I know this is already attracting me. When I walk into labor ward, the bed should be very attractive. Like it is a bed that has already been made, it has been painted, it doesn't have a rust, it doesn't have something. Sindio? Then, because like I'll go to this bed, already there is a mother that has walked into labor ward. This is her bed because we have few beds. I'll still wait on that other bed as I struggle. Because remember, mothers, when they are in labor, they walk around. And then when I deliver, probably I don't get a cup of hot whatsoever, or I don't get a hot shower. You will send me to a bathroom where like I will take a cold shower because the instant shower is not working. So for us even to attract these mothers, we need to do the basic. Mama tu apate chai, mama ingia kimaliza oge hiyo maji moto asikie ende kwa kitanda and stuff. So there are small things that we can fix that will basically attract some of these mothers. So we have webinars, and I think everybody seated here have joined. That is where, just be honest, who has never joined? So that we instill passion in you to join the next one. Who has never joined? Nitangalia majina zenu 30th. Then each session bring together county, national, frontline, and actually our webinar is, we get close to 1,000 participants. 1,000 participants. And we record it and we get it. I think the last one we even shared. That was our last webinar. We even shared. Personally, I missed it out. Because I told Grace, thank you, she shared for me. There was another conflicting panel that I was supposed to be in, but it was extremely good. We had the CEO of Blood, KNBTS, and he was very honest. Because even as county, if you deliver, he will also achieve. So we must work in collaboration and in consultation. This makes the webinars more than knowledge session. They function as structured feedback loop. So if probably you open the webinar to everybody to talk, everybody, there'll be a lot of muting and what, so we close everyone, but we pick messages from the text. Then the panelists and the what actually respond to that. So we also have county regular engagement. We secure meetings for some of the counties that do not have the link. We can give them a pack of even 1,000. Or even 300, even 400. If you want that one, we can do it for you. You can reach out to us. We could create topics. There's a webinar that we had. Homa Bay requested. They had a unique case. They say this may also happen in another county's host for us. We hosted and it went very well. I think it was something about blood clots. A very unique case. And the mother, I think the baby and the mother passed on. Something like that. But we convened for them and it worked. So if you have a unique case that you found and you want attention also the other counties to learn from you, give us the topic. We will do it for you. It is now county specific, but we'll put for you the platform, we'll do for you the design, we'll put for you everything. Yours is just to get in and log, but we plan together. Then convening, we usually have county leadership, national frontline, and as such, the practical solution. So every time we finish a webinar, we do a resolution. The resolution, there are things that touches on national government, there are things that touches on county government. And it works for us. Like I think there was a webinar we had on the look-alike drug. The one on the anesthesia drug. And I'm glad because the CS actioned. That one they wrote to KNBTS, they wrote to KEMSA, and I think something happened. I don't know whether you still have that problem, but you tell us if it has not happened, because if you don't give us feedback, it is hard for us to know whether that thing has happened next. And then we have, this is one of our webinars. This is frontline realities in hard-to-reach area. So we deliberately put Mandera and Baringo, because they have unique, the terrain, the geographical, the what, everything. And then we had Ministry of Health, we had also partners, and we had frontline healthcare workers. You can see Amenge is here, and then the chair actually does a keynote address. So we think through, and it is you guys who give us the topic. So now that you also know, you can come through your other team and say, I think we need in the next session, this is what is challenging across all the 47 county governments. You give us a topic. Then we put that topic as a webinar. So like another one, maybe just go quickly. I'm a bit fast. We had one on improving blood and blood products. We had one that is strengthening anesthetic safety. We had one on clot collapse and clues, lesson from PE-related maternal death. This is the one I was telling you, Homa Bay said we need to do it for them. And then we have saving mothers and newborns in Kenya in hard-to-reach countries. You've seen festive season, safe season. I think that topic was given to me by Maina and Amenge. They said there is a survey that was released and most mothers die during the weekend, some die at night, some die during holidays. So it was a very good webinar, And we ended up even writing memo to all the 47 county government to share with their governor the schedule of, and they took it seriously, by the way. They shared the schedule of how the hospital will be covered during December. Actually, it was December holiday last year. And we also told them what needs to be done, probably even for those who have remained behind, see how you can motivate them, see how they can also celebrate while they are still at work. Then there was one on maternal, perinatal, and response in the counties. It was also national. So so far this is the one that we had, but we are having one again on 30th. We committed that every month we must have one. We will not tire on that one. That is something that already, even if Katra will not be here tomorrow, my team know. The inter-county team know. So I know most of the time we are the ones triggering you. We are telling you, hey, we have a webinar, give us the topic. So we will be chasing you to be giving us. But if also as you sit here, you can start brainstorming on some of the topics, we can put it as schedule so that we don't think so much. We just say we put this one for this month, this, like that. Then we have this Intercounty MPDSR dashboard. I think I've spoken about it. It is all the 47 county government can access. They have the link. By the way, what we can do, if you're head of Sangine, we can give you that link. Because the custodian right now is the CHRIO. Get it from your CHRIO. You have a unique link county. Even when you have your departmental, look at the dashboard. The CHRIO will come and sit with you. Then you look at how your data looks like. Can we do that? But did you know that? So Charity as one of the way forward, I think we'll write to CHRIOs to share, because we've already told them we need to have this also discussed at the departmental meeting. So the ops, the pediatrician, all of you will be in one room to basically look at the data. We were always told we cannot leave the mother and the baby. Then create shared evidence base for leadership decision. The decision, it has data capture, analytics, review, action. Maybe we can have one, just in snapshot in 1 minute. After this, you can just project so that they see how it looks like. Sometimes you have a facility that is giving you more mortalities. If it is in Muranga, one county in Muranga, maybe it's called what? Kiharu. You just project Kiharu, you'll see what is happening in Kiharu. The last 1 month. We've already uploaded data for last month, so it is updated. So you will see what is, and then you will see, like when you see big reds in the map, you see that is the facility that is giving you more mortalities. So in the meeting, departmental meeting, you say, this is the hotspot. We need now to go and see why mothers are dying in this facility. So you move to that county. Don't ask them to come to your meeting. Move. If you do, tell me your directors, the chiefs, the what, you just do a small budget. If it is part of your target that I need this budget to be facilitated for me to walk into, and I know they will. They'll give you, because at the end of the day, they will also achieve as one of their indicator. So next. So this is how the dashboard looks like. I know there's a lot of light. Can you see? Maybe you can switch off these front ones. This is how the dashboard looks like. And I said we have all the 47. You know, this room is big, so you don't know where we switch off the lights. I think I'm going to go nyuma. Hapa hata mwizi akiingia uwezi toroka watakuona. So this is how the dashboard looks like. So can I give you 1 minute to take them through? Charity is one of our staff. She's a statistician by profession. I've converted the statistician, the public health officers, the legal people, all of them are now medical team. So they know. She can quickly take us through you look at the dashboard, and then you also look at how our website looks like, because I think I'm done with my presentation, right? Or there was the one on Tana River. Yes, as you set up, you can put for me the engagement as I talk. So on the engagement, we went to counties, but meanwhile set up, I can talk off the cuff. We said there are counties that are doing so badly, and we were targeting the first 15. And 2 weeks ago, we went to Kilifi, and we also went to Tana River. We engaged the leadership the leadership show a lot of interest. Sometimes it's easier for us to engage the leadership than the other staff. So when we create that link, we also bring on board now the county frontline healthcare workers, so that as COG speaks, there are also other frontline healthcare workers, so that even the governor asks the technical people what is happening on this, and then we had very good way forward from those counties. I remember in Tana River, one of the issues was commodities, and the governor that day was supposed to sign a supplementary budget, but KEMSA was owing, they were supposed to pay KEMSA 50 million, but they never paid. So KEMSA was not supplying that county. Actually, the governor said, I'm returning this supplementary budget right now, put the 50 million. And we had an engagement with the CEO of KEMSA. We called while we were in Tana River, and we said, don't tie these two things together. And actually, he accepted. That is how now we need also to work with the departments. In Kilifi County, the governor committed. When we talk about Kabetosin, he said, how much does it cost? 85. He actually told the HMT who were there, I want this drug up to the lowest level in the dispensary, and I want it by today. So I don't know whether it happened on that day, but we are having a follow-up meeting with schedule to have if the action points have been achieved. We were with the governor of Kilifi, and we were telling him, in one of the county facilities, sub-county facilities, a gynecologist have resigned. And it is one of the facilities that was giving them many referrals. And then he said, but I have 15 of Sangine. Where are all of them? And they had how many sub-counties? 7. He said, we will transfer that one. There was an advert we were supposed to make. What happened? You know, some of them already know what is happening. He removed a lot of block. And he said, we will do it and I will do it. And you know it has happened. So when we engage these counties and bring the CHMTs and then have another forum, like we had a whole forum of CHMTs and frontline healthcare workers from the sub-county, we could engage and we could hear. You know, some things are very strange, but there are some things that require leadership to quickly intervene. And you know, when we gave the report, the governor said they will implement the report. Actually, we are finalizing on that report, but we've already given them the snapshot. Those are the kind of engagement we want to have. And I said we are working with the MNCH champions to go with you, so that as even we are there, you're also telling them what really for you in your county. Somebody was telling this morning, greeted a friend and said, unajua tuonanagi, so nikasema tu kwa roho yangu, kumbe si ndio tunawaleta. So kuna wenye hawajaonana hapa 4 months, lakini tuliwaleta pamoja. So it is also something that we need to know. These are some of the photos that we went. At a point we were finding ourselves making noise. I remember walking in one of the, you know, one of the things that kept on coming up is like we have constraint in resource, we have shortage. I walked into one facility in the county that I visited, in labor ward. Actually, Amenge came and pulled me out because I stayed for almost 2 hours. They left and they were looking for me. I walked into that labor ward. There were 4 students, and there is 1 medical intern. And I think there were 2 nurses and something was happening in. Then this same facility were telling us they have shortage. The 3 nurses, student nurses, were writing notes, maternity notes, like I've conducted a delivery, it's an assignment. I was writing notes. And then there's a small baby from theater. Do you know, by the time a newborn, what I was taught, a newborn can only express a problem through crying. That neonate was crying. And then I have 4 people writing notes here. And then there's a newborn crying in the what is it called? The baby coach. And then there's a mother who is in labor. When I went to her, she was telling me, niinue kichwa, nishikia paki, nifanyie hivi. But I have 4 who are doing. I took their books. They all stood up. They don't even, I think we introduced ourselves, but they didn't know us. I took their books and I had a session with them. They were so scared, but I told them, parting shot, by the time you qualify and you live here, you will be used to writing notes. You will not know what is expected of you by a patient. So you see, we are not also, you can't complain when you have a 2nd year, 3rd year in labor ward. That is a resource. You must make use of them. You can't cry over shortage every now and then. So we need also to maximize on the resources that we have. But these are some of the pictures. You can see this first photo is the Governor Mungaro. I was there, that is the CEC for Health. This is a group photo. We went to Kilifi Hospital Newborn Unit. We were with a neonatologist called Felicitas. She was a noisemaker. At a point, I'm like, slow down. She's telling them, no, but you see, Your Excellency, like, you know, the fingers are like, I'm like, this is a governor, this is a governor. I kept on reminding her, this is a governor, because I cannot also talk like, to the governor like that. But you see, that is the passion. But the governor liked her. The governor really liked her. She was saying, you know, you give a lot of attention to mothers. We are forgetting the newborns, Your Excellency. You know, at a point, we are moderating a session. She has already taken the mic. She's ahead of the moderator. I really liked her energy. I really liked her. But that is like now saying we've removed a barrier between the leadership. Imagine they learn a lot. Even them through our visits, they learn a lot. So then this is Kilifi. This is the governor. This is the CEC for Kilifi. No, Tana River, sorry. But this is the governor, Governor Mungaro. He left. You can post that video. He went and talked about Kabetocin in a burial. And it went viral, by the way. And then here, this was healthcare workers. This was where Amenge, I can see Amenge carries a ball when you go with him somewhere. And then like he just throws the ball to you. Give me 2 things that you think we must change. And they give us a lot of solutions, by the way. So some of the challenges, like there are many, many challenges. I think you all know there are mass resignation. Right now we are getting some facilities, some counties losing. This is a waste of opportunities. And you've invested, probably you bonded 3 of Sangain. They went to study, wakarudi after 3 years. We were born for 2 years, wamemaliza, wameenda. Why? Because we are not also attracting and we are not retaining. One of the things that is coming out, I went to school with Job Group P, and I came back, I worked, and I'm still in Job Group P. It's a conversation that we already had with the governors. I think we need to, they will guide us, but we've given them the proposal on how we need to categorize the specialists. It's not only on doctors, but all the cadres that have subspecialty, because it is an additional value. That's the only way you can attract and retain. Like severe staffing ratio, Kwale, they have 1 nurse to 47 units. Kiambu, you have 2 nurses plus 80 plus neonates. We are not doing so well, but we will reach there. Next, some of the examples. Mandera, you can see what we have. Nandi, you can see what we have. Tana River, we have 1 gynecologist. That day we made noise. The county secretary made a call to a pediatrician. They I think, took to school, and they told her, they promised her good things. She reported that day before we left, and she joined our last meeting. So even right now, as we speak, we've engaged.
Mortality, with neonatal mortality being a major contributor to the under 5. And this stagnation means, for example, for neonatal mortality, for us to achieve the SDG goals, then we need to reduce neonatal mortality in the remaining, is it 4 years or 5 years, by 50%. And those of you who've interacted with data for last year, we actually, it had flatlined and there was a slight increase in the facility neonatal mortality ratio. So that means there's a lot of work to be done. We know where mothers and babies are dying. The top 3 causes of mortality is postpartum hemorrhage, hypertension, high blood pressure in pregnancy, and infection. And we know what is contributing to those deaths. We also know the 3 main killers of newborns is birth asphyxia, prematurity, and sepsis. And all these are preventable. And we have the knowledge to prevent all this. We also have, as we'll see later, there's been a lot of investment in maternal newborn health. And I think what we can pick from what Director Katra said in the morning, there are a lot of opportunities in the counties, a lot of funding coming to the counties that we need to know of so that we can be able to leverage that. And about MPDSR, we've had MPDSR. I think Kenya has been leading on this from 2016 and even had a national policy since then. And this has been revised in 2024. But still, mothers and newborns are dying. Besides that, we have a recent quality of care report which was launched last year, which shows glaring gaps in terms of infrastructure, in terms of even knowledge, basic knowledge on how to take care of babies, mothers and newborns. So there's a lot that is happening, but we still have a lot of gaps that we need to address. And critically for MPDSR, we have two components that are lagging behind. We've done so well in maternal mortality audits, but we've not done so well in perinatal death audits. For perinatal death audits, the emphasis has been on early neonatal deaths, but you are missing out on the stillbirths. And I know most of you are in the IMNHC Congress, and you saw about the stillbirth burden in Africa. And we really need to do a lot, because for us to improve survival, we need to address, because stillbirth is just a marker of how poor our health system is. So for us to improve, that's why we need to track stillbirths and make sure we strengthen the health systems so that we are able to improve. The other area that has been poor is on response. We're doing a lot of audits, and as we'll see, one of the key successes for the Intercounty MPDSR is in terms of the weekly audits, and also bringing into the loop all the counties to audit. But we need to ask ourselves critically, what are we going to do about the response? Is it only enough to audit, but it's more critically important to respond to what we are seeing in the audits? We know about the three delays: delay in seeking care, reaching care, and receiving adequate care. And I know this is a converted group, but critically for us who are frontline healthcare providers, from the first confidential inquiry to maternal deaths, over 90% of the deaths died due to quality of care. And this could be because of the health system, barriers that are inherent within the system. And we need to really see how can we improve quality of care. So as we look at the priorities that we're going to set today and tomorrow, one of the critical components will be on how, as Intercounty MPDSR, are we going to address quality of care. And this is why the Intercounty MPDSR is there. I think it was already discussed in the morning about mothers or patients not knowing boundaries. And we already know that we are sharing blood products, intensive care units, sometimes learning, sometimes specialized services. And at times we need to see, I think even from the discussions in the morning, we saw there's still gap. Besides having the intercounty, we still need to further strengthen intercounty, especially looking at those regional groups or counties that refer to each other. How can we further strengthen that component so that we don't have intercounty by name, but the counties are not talking to each other. It's not only enough to attend another county's MPDSR, but it's more important to be intentional in bringing those groups of counties that are sharing resources and also referring to together. We already have through the county several, for example, we have Jumuiya ya Pwani, we have the Nairobi Metropolis, we have the Lakeside or Western region, where there are several counties who are actually sharing resources. And we need to look at that. How can we further strengthen and reduce that fragmentation? And Intercounty MPDSR is a provider-led initiative, as we've discussed early. It's COG anchored, and it takes a health system, strengthening focus, and is data-centered. I know these are some of the areas that we really need to look critically. For example, when we say data-centered, it's not only enough to have a dashboard that we displayed, but how do we use data emanating from that dashboard for our advocacy efforts, also for improving our services. In terms of health system centered, we have the health system pillars, as we'll show later in the pillars for intercounty. How do we then work with COG to actually strengthen each of those pillars? Because as we all know, when a maternal death or a perinatal death happened, it's not because of one problem. There's usually a series of mishaps that happened that enable that maternal mortality or neonatal mortality to happen. So we need also to see how, that's why health system strengthening is quite key, looking at having that health system thinking. We think about the priorities that are set today. And these are the 5, you know, I'm touching somewhere, it's disappearing again. Yeah, these are the main objectives, strategic objectives. We have strengthened surveillance. I think we've mentioned that we are not sure of how many mothers are dying. And there's a lot of steps that are being taken. First of all, we now have a digital notification platform that has been developed. We also have digitization of the MPDSR tools. And these are opportunities that we have that as intercounty, we are able to be the first ones who will adopt those digital solutions so that we are able to strengthen surveillance so that at any one time, when we say 5 mothers died within our counties, it's actually 5 mothers because we have eaches which the community is reporting. We also ensuring that all mothers or all moms or babies who are dying at the facility are notified. We also have the second issue of institutionalizing quality maternal and perinatal reviews. This is quite essential because, as we all know, garbage in, garbage out. So if the audits are not quality, then we'll not have smart recommendations, and then we'll not be able to have clear responses. And that's an area that we really need to strengthen. As you listen to the audits that are happening, at times we are not able to have those very clear, to tease out the actual causes of death even from the narratives. There's a lot of missing data at times, and also in terms of how we at the end of it say this was the contributing factor to death. And we've also had the discussion about doing postmortems when we can. And apart from that is having those smart objectives that can actually be implemented. And as we look later is how can we do that? And part of that is building capacity within the Intercounty MPDSR, so that as we are stewarding the MPDSR, we can ensure that our teams know how to do MPDSR correctly and how are able to generate smart recommendations. The other is on the driving actionable responses. How do we move from just saying, this is what we need to do? How do we link those responses to accountability? And how do we link them and be able to know them? There are very many solutions which are already out there on tracking responses to the MPDSR. For example, when you are doing, it can become quite frustrating when you do weekly audits and the same issue or the same recommendation week in, week out. And it's glad to hear that the COG is strengthening the dashboards so that you can be able to capture the response, the recommendations, so that in case a recommendation is not actioned upon, we are able to escalate and have a discussion on it. The others is foster learning culture and strengthening accountability. And we have this theory of change. So maybe I'll just step back. We've talked about lack of effective MPDSR and governance, underreporting, and poor utilization. So at the end of it, we need to ask ourselves, have we, in the last 5 months, addressed the underreporting? Have we addressed MPDSR governance and coordination? Weak response to recommendations, what are we doing on that? And also inadequate capacity and commitment to accountability, both politically and also clinically. And those are the major gaps. And then we looked at what interventions we can do, and those interventions are falling into the pillars, which I'll highlight later. And then this included strengthening leadership and governance, strengthening the MPDSR process, in-depth analysis and the dashboards, and also inter-county collaboration and coordination. And from that, we expected that we'll have inter-county MPDSR committees, which have been institutionalized. And I think one of the things that this group has done is we've been able to do that, because at the moment we are having the weekly MPDSRs and happening. We've even catalyzed the establishment of that national MPDSR steering group. And that's a result of the engagement that you are having. The others is the improved MPDSR data systems for decision making. So the other area that we'll look at that, how have we done that? Inter-county QI collaboratives and coordination, empowered workforce, commodity security, healthcare financing, and maternal and child health. And we looked at this to have several outcomes which are listed there, but the main goal of inter-county MPDSR at the end of the day is that we reduce preventable maternal and neonatal mortality. So that whatever we are doing, if we are not able to reduce maternal and neonatal mortality, then we will not have achieved our function. So this is the theory of change. We can improve on this, but it's fairly broad and can accommodate most of what we want to do. The second is we divided this into pillars that we thought would save lives. We had one pillar on governance and coordination, And one of the main things that we're going to do here was to formalize the Intercounty MPDSR within COG, which has been done, and to have a dedicated coordination unit. As we've said, Amenge and Mary and the others are at times quite busy and not to be able to do the day-to-day. I know the director, you've seconded people to support, but maybe it's good to see how can we have that, even if it's one person who runs around, who ensures that the reports are being made, who ensures that they schedule the webinars, they share if knowledge products with the team, or if there's an update, who ensures that they can support the statistician within COG to ensure that the data is validated and all that. And also in terms of also driving the M&D component. That will be quite critical so that we have this particular whose responsibility or unit is on Intercounty MPDSR. The other one is to look at how to streamline the structure. We've really talked about Intercounty arose from the Nairobi metropolis, those group of counties. How do we strengthen that initial thinking and have the coastal one, where Tana River or the northeastern ones, the ones who are referring to each other, or the western one, how do we have that? So that we can also reduce the burden of everyone to join into every other weekly meeting. You know, you will join into your caucus once when your caucus is meeting, then you don't have to join Nairobi, which might not resonate quite clearly. But still see, how do we still ensure that we're able to have cross-learning within the regional caucuses? The third pillar was on high-performance surveillance review systems and the notification of deaths within our counties. How do we ensure that they're happening? Talked about the opportunities which are there. The maternal or perinatal deaths within 7 days. How do we ensure that we improve on that? That all neonatal deaths are audited as required within 7 days. So I think that's one of the things that we should have as our dashboard. Have we as a team, because we need to hold ourselves accountable and be able to say that in my county we've been able to improve on the proportion of neonates who die who are being audited within 7 days. We also have some counties who are not yet auditing all the maternal deaths within 7 days. It's not 100% across board. How do we hold ourselves accountable and say that we've been able to audit all the maternal deaths, all the neonatal deaths within 7 days? And those should be now what we track as a group. The other area is on quality assurance for all reviews. How do we ensure? I know there are some counties which still need a bit of hand-holding in terms of even how to conduct an audit. How do we develop a training package as we do the peer-to-peer? You can go to a county and tell them, this is how to do an audit. When a death happened, this is how you serialize in terms of timings from the time the mother came in. This is how you develop smart objectives. This is how you have someone accountable. How do we do that so that all the audits are quality? The other one is quality improvement and service delivery. In my first meeting in the Intercounty MPDSR, I remember we talked about this. We talked about improving antenatal attendance and also on, was it essential newborn? Can't remember what the neonatologists or the newborn team recommended. And we said we are going to do this across board so that we'll be able to learn from each other on what is working, what is not working. We have the high impact evidence interventions. For example, in maternal health, we have the PPH bundle. How many of our facilities or how many of our moms are delivering with the calibrated reps? And how many PPHs are we managing with a bundle? So these are some of the metrics that we can use for the QI collaboratives. Because for us to move from just the audits to response, to have an impact, then we must act on what we are able to do. And that is implementing high impact interventions. And that is within our reach because we are the ones teaching them in charge of the labor wards and attends our facilities. And then, so that the discussion should now move as we move into the health system enablers, how do we advocate to have the PPH drips, to have the bundle, the tranexamic being available in a health center, and having those trainings cascaded to the health center or to that lowest delivering facility. How do we advocate for essential newborn, vitamin K, code care for chlorhexidine, even warmth when the baby is delivering? So these are some of the things that we should be able to, as an intercounty, now move to, looking at those responses that will enable us to save the lives of mothers and babies. And then the other one is on the peer-to-peer learning sessions that we are already having. So that's the other achievement that we've been able to derive from the Intercounty MPDSR. And also the other area is on data and data analytics. I think we've done that quite well. Now that we have the national, the COG dashboard, which is accessible to the counties. But how do we move from the dashboard that was displayed today so that we go to the responses, tracking the responses, and also tracking of the notifications, the death notifications that are happening, the deaths that are happening. And how do we use data now for decision making? Besides that, there's the National Learning Platform. I think when we met, people said they want a conference for intercounty where they'll share the learning practices. I think we said we want to do a bulletin that will be sharing outcomes from the MPDSR processes. So these are some of the things we need to think about. How do we now action some of those commitments that we made? Then we come to the health system enablers. That's the last pillar. We talked about workforce development and support. And one of the things that, as Director Katra highlighted, I'll highlight it in another slide also. As a country, a lot has shifted in the past months. We have a lot of investment coming into the counties, and a lot of the investments at times, like for Beginnings Fund, is centered in those high volume facilities for the counties that will be supported. And as Intercounty MPDSR initiative, you will be involved. The other things is like, I think the World Bank projects that is coming to some of the counties. There's a lot of investments that are coming to the county. So it's for us to see how do we know these investments so that we are able to tap into them and to advocate that those high impact interventions are funded and the implementation is not on book, but it's actually happening at the facility level. The other is commodity security on blood. I think we had that national webinar on it, on the uterotonics, on caffeine citrate and what the newborns want, the vitamin K. And then also there is smart advocacy. We've done a lot of advocacy. I think kama kuna mtu ajui Intercounty MPDSR hajakuwa Kenya in the last few months. We've done a lot, and the governors are also talking about it. But now we want them to commit. Let them commit tangible. For example, let them commit that we are going to buy calibrated reps for all moms. If it is Hitsebo Kabetosin has said, let them commit on that. If it's buying baby warmers for every delivery unit or maternity, let them have that. So let's have that tangible so that you can, at the end of it, after you've done the advocacy, you can say, I've been able to mobilize this amount of funds. So that it's not only, sorry for saying lip service, but it's actually something tangible that now we can improve services. It's promotion, yeah. So the other one is one of the other things that we might need is the budgets have already been done within the counties. Did we participate as inter-county? But there's still an opportunity. I think maybe COG can tell us when does the window open that the team can participate in and look forward to. Because we are using program-based financing or budgeting. So at times we have lines, for example, for newborn, so that in account you'll have a newborn budget. At times you have nutrition, at times you have maternal. So we need to advocate so that our requirements are budgeted for. Because if they're not budgeted for, and we come and advocate later on in the year, it might be too late. So that if we've not done that earlier, we have missed that opportunity at that level, so we can only look for finances outside the county, but not within the county finances. So we need to see how can we develop that capacity as a team, and how can we implement that. The other area is on impact. I think I've been talking to this as we were discussing. It has funny colors you might not be able to see, but it takes the pillars into results areas and output areas. So I was thinking about prioritizing. It might be good to think about, so that if you want to bring the inter-county investment case to life, we need to have a work plan on these lines. Also priorities. Looking at every pillar is an outcome area. For example, the first outcome area is enhanced inter-county MPDSR coordination and governance. And we have some outputs which we can work on as we prioritize. We also have the strengthened MPDSR surveillance response in terms of timely and complete notifications, in terms of quality MPDSR audits and reviews, and smart recommendations. What can we do on that? The third one is an output on improved quality of care. This is where we need to do a lot. We've not done much on improving the quality. We need to be purposeful on that so that we see, for example, are we able to have commit to any high impact intervention that will champion within our facilities. If it is on maternal, what on newborn. And then there's also the fourth, which is improved learning and accountability, and enhancing use of data, MPDSR data, and research and learning agenda. So that's the other thing. I think we've heard about Marifa, we were told in the morning. We need to see how can we, for us to share our outputs, then we need to start writing and documenting our results. And also doing, that people will be interested in. For example, we talked about, we want other counties or countries to implement, or as we implement the QI collaboratives, we can document that and share with the other counties to implement whatever we've seen is working, as we also put it in Marifa. The last one is on the strengthened health performance through empowered workforce, commodity security, and healthcare finance. What are we doing at the health systems level? So we need to have priorities. For example, how we are going to advocate for availability of commodities, availability of HRH, and also health financing. And also a functional referral. I think in the morning it was mentioned, referral is a challenge, and there's already a policy that is being developed. How do we show up, and how do we implement that guidelines within our counties? Because the context is different for each county. So these are some of the areas that we really need to think through as we come up with the priorities. And this is some of the expected outputs. We expect reduced mortality. We expect enhanced data quality and completeness. Data quality and improvement is quite essential. And one of the things that has been shared is even the data we have in KHIS, and this is the data that is being used for procurement and all that, is not accurate. If you compare the source and what has been uploaded, they are not. How do we support that within our facilities? And I know there are partners within the counties who are supporting data quality assessments. So how do we ensure that as we do, whatever data is coming out of your facilities of quality, and same to what we've talked about, maternal death data. The other area is enhanced inter-county collaboration and coordination. How do we measure that? Is it by how many weekly meetings are happening, or how many inter-county or regional meetings are meeting? Is that the measure that we'll use so that we can know that inter-county MPDSR is happening? I think someone mentioned is how do we document referrals, and how do we capture that these two counties met because of a maternal death? Because that should be our measure of success. We're inter-county. So we're meant to strengthen that collaboration and coordination. Strengthen quality of care. We've talked about response, and we want quality of care to improve within the facilities. If it is in, for example, Kiambu, or it is in Kwale, or it is in Malindi or West Pokot, how do you say the quality of care has improved? And we can take a few proxies for quality of care and use those ones as a yardstick so that we can say, because you are participating in inter-county, our response has improved and our quality of care has improved. Is it having a reduction in mothers who are dying because of postpartum hemorrhage? Is it the number of asphyxias or neonates who are dying because of asphyxia? Because we've implemented the labor care guide, so we've reduced asphyxias being attributed to prolonged labor. Is it sepsis that as inter-county, we've had these meetings and we've reduced sepsis within our facilities? Or is it also, I think, as she was describing her experience in Garissa, one of the things which came to my mind is safe surgery. Have we started implementing safe surgery with the WHO checklist within our facilities? That is within our reach. Because we are the ones who are in those theaters, or we are the ones who are those NBUs, and we can improve IPC or those standards within. Yeah. So how do we measure quality of care? So we need to look at what proxies we can. How do we measure increased accountability? I know at the moment you are saying we've been able to do that qualitatively because the governors are talking about in MPDSR. We have that qualitative aspect which has improved on accountability, but we need to go further. And then strengthened health system with the empowered workforce. The investment, so moving forward, the investment was for a request of 531 million over 3 years, and this was catalytic because it was not meant to do everything. It was meant to support what we've just described. And it was to be front-loaded so that you have 80% upfront, so that you have those foundational systems in place. For example, having the clinical interventions, the capacity building, the dashboard which has already been developed, and also so that as we go along, these systems are already in place so that we are building on them in the subsequent years. And it was only also leveraging on the existing budgets. And the return of investment was to save 2 to 4 mothers saved every day, and that was coming to 990 lives saved. It also had a newborn component, but as just to strengthen this, we have the newborn investment case, which has more depth on newborn. Yeah, so which has shown it's up to $15 return of investment for every dollar invested for newborn. That is if everything as the newborn investment is implemented, we'll have that return of investment. And this is not only about lives, it's also about strengthening the health system, increased efficiency, better data for planning, an economic return, and accelerated progress to SDG. And this was our call, that together we can end maternal and newborn deaths, and we called on people to come and invest in the investment case. And we've done a lot. And just looking back, it's now 5 months. The momentum is real. I hope it's a feeling for everyone that we have real momentum, just not only from in terms of maternal and newborn deaths, addressing maternal and newborn deaths. There's a lot of interest. And just to show a few things that has happened in those 5 months, a lot. We had the Ramka nutrition investment case which was launched. Just within that same period. We also had the quality of care guidelines which are also launched. We also had, when we were launching the MPDSR, the newborn investment case was launched a few weeks later. We also have a national MPDSR steering committee which was inaugurated by national government. Kenya hosted the IMNHC conference, and in that conference a lot of commitments were made by government and partners, and also the Wenya acceleration plan, and there's a planned RRI on maternal and newborn. Besides that, We've had digitization, which is happening. We also have SHA. So as we look at our priorities, also let's be cognizant of what is also happening. Because some of your counties will be doing an RRI, Rapid Results Initiative. And that might mean more resources coming to the counties. We also have I've talked about Ewene and MNC. Director talked about Beginnings Fund, which is coming to some of the counties. We also have had the US G2G, which is still on hold. But, yeah, it has MNH components. And we have partners who are implementing within your counties. That's Nairobi and others. So this funding is still ongoing and it's happening within your counties. We have the GFF World Bank. Mabel talked about it, which is going to address commodities and other things within the county. But what we need to also, and then we had the Healthy Bats Initiative, which was launched, and we'll start from Nakuru. And with all this, you can see the momentum is there. So we really need to have, is it our ducks in row or road, they say? We need to have our priorities right and see how do we leverage. For example, the World Bank, which is going to do MNH commodities, we have an opportunity to advocate at the county level to have those commodities for newborn and maternal health that we want. It also has a bit of component, I think maybe they can tell us more on quality improvement or the high impact interventions that will be implemented by the county. And these resources, some of them will come directly to the county. Told HRH for Beginnings Fund. So there's a lot that is happening and the momentum is there. So we really need to also, maybe when an opportunity arises, or if a database can be shared with the intercounty, so that you know which resources are there within your county, which you can leverage on, because it's quite important. These are some of the priorities that are teased out, but I think we've discussed as we are going along. On governance, we've talked about the coordinator, the coordination unit that is accountable and dedicated, the regional county blocks, this is a consideration, and also advocating that the Intercounty MPDSR we are talking to governors. Let them commit and put you in their work plans as they do the annual budgets. The other area is on high performance surveillance. We've talked about the notification, the audits, a quarterly MPDSR progress scorecard. I think Saturday we had one. We've had 5 months, but can we make it routine that we have a scorecard on MPDSR coming out weekly so that you know, like, what the numbers are in terms of mortality, where we are in terms of the audits, where we are in terms of the responses. That will be important. Then you have the quality improvement. Let us think about how to set up the QI collaboratives within. Let us commit to some improvements on quality, responding to what the audits are telling us. So that's why if we have someone dedicated, we'll task them to, when all the weekly audits happen, that person at the end of the quarter summarizes what is coming from the audits and the QI processes take up. Besides that, we also have, can think about the CPAP, neonatal resuscitation, or essential newborn, or small and sick newborn, for those facilities that so as we did think about priorities for newborn, the investment case becomes a very key component that we need to use, because it already defines what needs to be invested at what level, and it also has calculated the HRH needs at each level. So that is one tool that, as we talk about prioritizing, we already have a tool. We have the peer-to-peer learning. How do we strengthen that? We've talked about data and data analytics. A scorecard. We talked about that we have a scorecard. We talked about having a running agenda within the CEC's scorecards on maternal mortality. Is that something we still want to have? And then apart from that also is the learning platform, the webinars. Beyond the webinars, how can we enable healthcare providers to easily get the information and capacity needs that they need? Health system strengthening. There's workforce, commodity security. So one of the things I learned about commodity security is, let's not walk alone. The pharmacists who decide on what needs to be prioritized at times have not been appraised on the updated guidelines. So how do we also involve the pharmacists? How do we also involve the nutritionists? Because maternal nutrition is quite important. How do we move with the nutritionists as we do the MPDSR? So we need to see how to expand the scope and also how to define a way to engage those other groups that are critical to the survival of moms. We talk about blood and the commodities there. SHA benefit package, I think it's a big issue. How do we continue advocating so that it can serve and we can close those bottlenecks that are there for moms and newborns to access? Community referral linkages, that's the other area, that how do we as intercounty, because the verbal autopsies or community MPDSR is a critical component. So that's the other group that we need to think about, that as we strengthen the intercounty. And smart advocacy. I know ring fencing is political. Yeah, but luckily for some fundings, especially like the World Bank, I don't know whether it is ring fence for MNH, for the commodity purchase. So how do we ensure, but as we said, if we work with the pharmacists, advocate pharmacists so that they can prioritize MNH essential commodities in their procurements, then we might be able to have that. But generally, how do we have that, strengthen our smart advocacy? So I think those are the main things. And then I've just put up this is illustrative, that at the end of it, we have to have very clear metrics on where we want to go. I know one of the metrics that we've already achieved is this one, the first one, that 47 counties are having active intercounty MPDSR because they're having weekly meetings. For those ones who are able, or they're having MPDSR in one form or another. But how do we ensure that we have the 90% notification, all deaths, cross-boundary deaths are reviewed jointly? That should be our metrics. And then about the QI, that's another area that we can talk about. And then we already have a dashboard. And then about budget lines dedicated to not only intercounty, but dedicated to maternal and newborn. How do we have those in the budgets? So I'm just putting this as an illustration so that as we go into prioritization, yes, we can have a lot, but we also need to ask ourselves at the end of it, how will we measure success? And then for each priority, let's ask ourselves the so what, that yes, we are implementing this. Sorry, my time is up. I should be leaving, sorry. Yeah, so I'll leave this. This one was just, we might just do this tomorrow on just getting the sentiments on the priorities so that each one of us will participate on priorities, but I can maybe, so I'll come to an end there. Sorry, I have an urgent meeting starting at 4 and I'm already 8 minutes late. So if you're still here at 5, I'll come back for any question. But can continue the discussion tomorrow. Yeah, asanteni.
We need to appreciate better. Appreciate better. Just clap and back a Katie. Just continue clapping. Thank you very much. Thank you very much. There's a verse in the Bible that says something to do with kazi ni mingi, lakini wafanyikazi ni wachache. Is there something like that? Kwa wale wanaamini kwa ile Biblos. So you'll find the chosen few tend to really be of, like he's almost being fired for being late in that meeting. The director is doing another session where she's supposed to be opening some managers something, a midwife, so she has to do some things. I'm sure the president ametoka a few minutes ago amekuwa akifanya kakitu. There's so much happening, sindio? Now, ladies and gentlemen, I think that was justice. Do you agree? Are you finding a place where you can